Very good afternoon. Welcome to all our leaders of IMA and members and the delegates. So, I am Dr. S. Jayaraman, Secretary of IMA AMS. Welcome to this fifth webinar of Indian Medical Association Academy of Medical Specialties. So, today we are going to have two interesting important day. World Asthma Day and World Hypertension Day. We have star speakers and star moderators. So this is the invitation. So we have plenty of leaders, national and our Tamil Nadu state leaders and all the star speakers. So this is the program agenda in brief. We'll start the meeting with a prayer. May I request Dr. Adar Sendilkumar for the IMA and physician's prayer.
Yes, sir. Thank you, sir. Very good evening. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands and clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all the guile and worldliness, that with the simple faith of a child I rely on thee. I am my prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you, sir.
Thank you very much. May I invite our IMA AMS chairman, Dr. V. Rajesh Babu sir. Dr. Rajesh Babu sir is a senior consultant, neurosurgeon, and head of the department in the Ganga Hospital, Coimbatore. Dr. Rajesh Babu sir is a former president of Coimbatore IMA. Currently is holding chairman organ donation committee as well as the Academy of Medical Specialties of IMA TNSP. Over to Dr. Rajesh Babu sir for the welcome address.
Good afternoon, everyone. First of all, I welcome our president, Dr. P. Senguttuvan sir, for joining this CME program, which is being conducted by our Academy of Medical Specialties for the 5th month. I welcome our state's honorary secretary, Dr. Karthik Prabhu sir, and I invite our vice chairman of IMAMS headquarters, Dr. Amudan sir, and the state president at 2025, Dr. Sridhar sir, and immediate past president, Dr. Abul Hassan sir. Today we are having this program. In this month, we are going to have this Asthma Day. Actually, today is the Asthma Day, and we are celebrating the World Asthma Day today with our CME also. And also the Hypertension Day also coming in this month. So we are conducting two CME together in the same platform. I welcome the speakers of the day, Dr. Govindasamy and Dr. Cicely Mary, and the moderators of the day, Dr. Yelango and Dr. Chokalingam, for this nice CME. The only one request I like to put forward to all the participants are, you people, most of the people are the specialists. I invite all of you to please become member of the Indian Medical Association Academy of Medical Specialties, because the membership fee is hardly 1,180. Actually, we are having totally we are having 45,000 members in our IMA at present, and only 1,000 AMS. So I invite and request you, all of the people who are having the degrees above MBBS, diploma or degree, please become the members of the IMA AMS and utilize the benefits of the IMA AMS. Because through IMA AMS, you can conduct the courses in your specialties, and you can be one of the faculties and help our people who are not having the talents to improve their talents. So I welcome you all for this CME. Thank you.
Thank you very much, Chairman Sir, for your valuable comments about this IMA and all. So, may I welcome our State President of IMA TNSB, Dr. P. Sengutuvan Sir, for the presidential address. Over to Sengutuvan Sir. Sir, unmute yourself, sir. Sengutuvan Sir, unmute, sir.
Right. Thank you, Dr. Jayaraman, for your kind words. Respected President-elect Dr. Sridhar, respected past President Dr. Abdul Hassan, Honorary Secretary Dr. Karthik Prabhu, AMS Chairman Dr. Rajesh Babu, Secretary Dr. Jayaraman, Dr. Adar Sendil, and speakers of the day. Thank you for the opportunity. I think Indian Medical Association Academy of Medical Specialty is doing a wonderful job, and every time they are giving different topics, which is useful to the delegates and all the participants. So this will be kind every day, branch asthma day, hypertension day, every day they are celebrating. And with this, they are combining the CME program and doing a very good job for the Academy of Medical Specialties. So I already requested all the delegates who are attending this program may please join as a member of the Academy of Medical Specialties, and you can sort your branch level when you have got minimum of 20 members in Academy of Medical Specialties. With these few words, thanks for the opportunities. Over to Dr. Jayaraman.
Thank you very much, President. Thank you, sir. So, we'll move on to my Secretary's report. I am Dr. S. Jayaraman, Secretary, IMA AMS. Our Chairman, Dr. V. Rajesh Babu, sir. Our Secretary, Joint Secretary, Dr. Adar Sendil Kumar, sir. So, this is our AMS team of IMA TNSB. And today's, this is the, we'll start with, so last month, we had several activities to start with the monthly webinar. Every month, we have a first Thursday. So we do a webinar program for all our IMA members. So last month, we conducted the World Parkinson's Disease and World Hemophilia Day. So we had a wonderful talk by the star speakers. So throughout the Tamil Nadu and other. So we had a celebration of World Health Day, the theme behind Healthy Beginnings, Hopeful Futures. So we did a lot of awareness activity on the day. And in Coimbatore, our chairman, Dr. V. Rajesh Babu, sir, as a course director of the Neuroscience Forum, conducted the All India PG's webinar in neurosciences. There are star speakers, discussed the various topics like early experience in surgical treatment of basilar top aneurysm and management of approach to Parkinson's disease by Pramod Kumar as neurophysicians from NIMANS, Bangalore. And our course directors, Dr. Rajesh Babu and Vikram Muthusubramanian, organized this program on behalf of the Coimbatore IMA AMS chapter. And I participated as a guest of honor in Chennai IMA Punamalai High Road branch as a guest of honor, and sensitized all the members about our Academy of Medical Specialties facilities, programs, and various fellowship courses, membership fee, everything we have discussed in detail. A lot of members joined. You all know very well, IMA Punamalai High Road branch is one of the vibrant branch. Through Prem Kumar Satya, late Dr. Prem Kumar Satya, I joined this AMS. So currently, I am the immediate past president of the Villuvakkam Ayanapuram. So in our IMA AMS, there are lot of fellowship courses. So these are all the courses for our IMA members. The eligibility is very clear. IMA and AMS member is a mandatory. So we have more than 45 courses are available. This is for the short-term courses like 4 months, 6 months, and 1-year courses. Both online and offline are available. So offline classes in the hospital. So we do the programs. This is for our own members' benefit and fine-tuning their knowledges. So this is not accredited by any of the medical council or any of the university and all. This is our own IMA banner. We are doing the courses for our own members' benefit. So kind request, kindly go through this. Those who are specialty hospital, running the hospital, you can start your program and you can send the course module. So we'll do all appropriate course allocation and all. So kind request, kindly go through and you can start the fellowship courses in various disciplines. So these are the fellowship already we are doing that last year. Laparoscopic IMA course and diabetic retinopathy course in Coimbatore, and we have arthroplasty course and we have infertility course. All the courses so is running for the past 2 years in Coimbatore, and in Chennai MGM Healthcare, we have started sleep med IMA courses. So this month end we will be finishing 6 months, and July 1st onwards we will be starting the second course, fellowship course in sleep medicine. And in Trichy, under Dr. Ravi sir, conducting the Regima regenerative medicine course. Again, July they are going to start the second batch. May I request everyone kindly go through and join these courses. This is a 6 months course. Minimum criteria is the 4 classes per month, all Sundays only, 2 online classes, 2 offline classes in the center. So you have to visit the center, and you can do like a workshop kind of thing, hands-on everything. So I request everyone kindly go through our team on newsletter, everything available here. Any queries, please feel free to call me or our Joint Secretary Adar Sendil Kumar or our Chairman Rajesh Babu sir. So with that, we are going to start 3 more courses in this year along with IMA TNSB. There is a cosmetology course, there is a Cosmet IMA, and a critical care course, Critic IMA, and the hospital digital marketing courses. So I request everyone will update periodically. Before the State Council meeting, we will announce officially through the Timor newsletter. I request everyone kindly go through, and you can update, you can utilize these courses. Now we'll go for the felicitation by our leaders. May I request our AMS Headquarters Chairman, Dr. Ramneet Singh Bedi sir. May I welcome our Vice Chairman of AMS Headquarters, Dr. V. Amudan sir, for the felicitation. Amudan sir.
Thank you, Dr. Jayaraman. Am I audible?
Audible sir, welcome sir.
Yes. This hypertension and World Asthma Day program is very good. And for the hypertension speech update, we have none other than our doyens in cardiology, that is Professor Dr. Chokalingam. And I remember my younger days in the when I did the MD postgraduate course. My topic for ICMR Senior Research Fellowship was epidemiology of hypertension, where I took the blood pressure recording from various sects of people of Madurai. I screened a village near Madurai called as Uttangudi, and various work groups, TBS workers. And then I went to bank to record the BP of the bank employees during their work. So what I found was very amazing. The highest blood pressure was seen in bank employees. Record incidents of 20% of the bank employees had hypertension. And it was least among the Uttangudi villages. At that time, Uttangudi was a village, and it was around 8%. So we published this in JAPI. I don't know how many publications in epidemiology have come from Tamil Nadu after that, but this is the reality. The 20% of office goers have hypertension. So we should not take hypertension so lightly. And our Professor Chokalingam sir is well known for his speech on update in hypertension. I think he will be talking on that. Now I very well appreciate the work which is done by Dr. Jayaraman and our chairman Rajesh Babu in AMS. I think with this speed of work and the courses which are being conducted, I think we will be able to secure the best chapter award this year also. Congratulations to Dr. Jayaraman and Rajesh Babu sir.
Thank you very much, Vice Chairman Amudan sir. Definitely we'll do all good things. Every year we'll try to get the best chapter award in India, next level. Thank you very much, sir. Thank you. May I request our IMA Honorary National Secretary, Dr. C. Sairam sir. Okay. May I request our State Honorary Secretary, Dr. S. Karthik Prabhu sir, for the felicitation. Karthik Prabhu sir.
Respected President, leaders of AMS and all the leaders of IMA, good afternoon everybody. I think it is a nice topic that both breathing should be very good for low pressure. Breathing exercises reduces pressure. So you ideally combine both. So it's a good one, sir. And more than the online programs you're conducting, I would like to really appreciate AMS for collecting over 21 specialty association contact details, especially through Dr. Rajesh Babu, because IMA Tamil Nadu State has debuted the work of regularizing the case sheet patterns in each specialty with Tamil Nadu Medical Council, and work is in progress. Letters have been sent. The date of the meetings will be announced shortly. So through this medium, where all specialists are also there, I request your respective specialty association heads to be in touch with Dr. Rajesh Babu for who not a name is not included, because there are some recommendations coming up from the medical council as well, so that the mistakes down the lane are less, which will also help us in our PBLSS thing also to decrease the number of cases for doctors. So good initiative, sir. Nice work going on. Best wishes. And 2 new courses approval has been given. There are certain final this thing which has to be done. And once that is through, I think Dr. Jayaraman sir will be announcing probably in the next meeting. Best wishes to everybody, and I congratulate the speakers and the moderators, all with great wisdom you have chosen, sir. Best wishes to you. Thank you.
Thank you, Karthik Prabhu sir, our Honorary State Secretary. May I request our State Finance Secretary, Dr. Gauri Sankar sir. May I request our immediate past President, Dr. K. Abul Hassan sir. Our President-elect 2025, Dr. B. Sridhar sir. Okay. So with that, I conclude this thing. May I request our Joint Secretary, Dr. Adar Sindil Kumar, please take over and start introducing the topic and the speakers and all. Over to Dr. Sindil Kumar, sir.
Yes, sir. Sir, shall I share the screen?
Yeah, please.
Okay. Very good evening, all. Now we are going to the web session. The first session is called a brief of fresh air. The moderator is our respected person, Dr. Yelangovan sir. He studied MBBS from Stanley Medical College and Diploma in Tuberculosis and Respiratory Disease in Madras Medical College. He secured the first rank and is MD from Stanley Medical College, FRCP from Glasgow. And he received the Best Doctor Award in 2023 from Economic Times Outlook India Today, in 2024 from Outlook India Today. And he is senior mission Bronco. He is the academic coordinator in Apollo Hospitals. He was the president of the Indian Medical Association, Apollo Hospitals, like Chennai. He is vice president of First Association of Pulmonologists, Tamil Nadu. He is a member of the board, First Journal of Association of Pulmonologists of Tamil Nadu. He is a founder member of organizing committee, Tamil Nadu Pondicherry and Pulmonology Conference. He was the member of Disease Management Association of India. He is the former member of Institutional Ethics Committee, the Tamil Nadu Dr. MGR Medical University, Chennai. We welcome Dr. Yelangovan sir. Kindly moderate the session, sir, and kindly introduce Dr. Govindasamy sir, please. Dr. Yelangovan sir, please.
Yeah, thank you very much.
Sir? Yes, sir.
Can I have thank you very much for Indian Medical Association for having invited me to chair this session on World Asthma Day. And we have none other than Dr. Govindasamy, who is a budding young pulmonologist at Tirupur, who's going to give the talk today. Dr. Govindasamy was our postgraduate in the Department of Respiratory Medicine in Apollo Hospitals. And as an academic coordinator, I've had about the last 2 decades of experience of training national board candidates. And I would Dr. Govindasamy as the best person who had a combination of science and public relations. Of all my postgraduates, he stands excellent in the last 20 years of my experience in this field of respiratory medicine post-graduation as a person who delivered on the ground. Because a lot of people, if you see, I will talk about it, but then I will go through the slide of Dr. Govindasamy, who did his MBBS in 2009, 2015 in Savitha Medical College, did his DNB Respiratory Medicine 2016, 2019, Cleared the European Diploma in Adult Respiratory Medicine in 2019 EDARM and worked as assistant professor in SLIMS Pondicherry. Was an examiner for BSc Respiratory Therapy under Dr. MGR University, who's also a fellow in APSR, ICS, ERS, and CHEST. At present, a consultant interventional pulmonologist in Arjun Hospital, Tirupur. Many times we see gold medalists, not all of them, but sometimes we see them who are very good academically and not shining very much in practice. But Dr. Govindasamy was one postgraduate and a pulmonologist who excelled in interventions and in presentations, as you see him now when he's going to present to you on the World Asthma Day, which is the Tuesday of month of May. And this has been happening for the last about 30 years by the Global Initiative for Asthma, which Dr. Govindasamy will be talking to you about. And one unique selling, we say everybody has got a certain, a certain hallmark of certain excellence. For example, Einstein, we know, is scientist ever. Govindasamy, bit of time, come out as a pulmonologist in Tamil Nadu, who delivers to the population and who delivers to the medical community on medical education. With these words, I kindly request Dr. Govindasamy C to start his talk, and then we will have the question and answer sessions. Thank you.
Sir, Dr. Sendil sir, just a word about Dr. Ilango's father.
Yes,
He was
sir.
a famous asthma consultant and allergy consultant in Pershogam area, Dr. Rex. Just to add on,
Oh, super.
Ilango
Super,
to
sir.
come
Super,
under
sir.
the family
Ilangon,
of
sir,
asthma.
kindly give a brief. Ilangon, sir, kindly give your brief introduction towards the topic, sir. Then only the speaker will speak. For
Now,
your kind words.
asthma remains a medical enigma. The word enigma comes from the Second World War, where there was a machine where they could encrypt or decrypt what the Germans were coding during the Second World War. The Germans had a machine called Enigma, where you can send your message in code and nobody will catch it. So the word enigma in English means it's still a mystery. If you look at the textbook for medicine, if you look at Davidson or if you look at Harrison, 80% of all diseases, if you look at the etiology, will be idiopathic. From hypertension to diabetes, I mean, the etiology will be discussed in details over volumes and volumes, but ultimately, if you see, the cause remains unknown. And there are multifactorial reasons for why this is happening. But when you come to asthma, the same thing happens. It is multifactorial, but mostly it is genetic. They have divided this into intrinsic and extrinsic, but in my experience, I have seen that there is not a single person who doesn't have allergy who becomes an asthmatic. So asthma remaining an enigma in medicine, research is still happening at different levels as to exactly the real reason for what asthma is. But asthma basically comes as an allergic disease. And when I speak to the public, I always say asthma is an allergy of a cold from the nose which drops to the chest. And the most important part of asthma, and especially in pulmonology, is it occupies around 60 to 70% of our practice in terms of COPD and asthma, where it is an obstructive airway disease. And the mainstay is inhalers and nebulizers. Now, the experience in using inhalers and nebulizers from a corporate hospital is immense. And Dr. Govindasamy will be telling you that inhalers and nebulizers, if used very well, the quality of life in asthma patients will be excellent. And the thrust of the talk today, and for any World Asthma Day or for any consultant pulmonologist to talk, is that please switch over from tablets to inhalers and to nebulizers. The next request would be that once you switch over from inhalers to nebulizers, don't go on for intravenous darbepoetin and decadron. Those are outdated treatments with a lot of potential risks in terms of tachyarrhythmia and cardiac asystole. There is no role for intravenous darbepoetin presently, and the only role is when we have IV aminophylline in respiratory failure as a drip. Even a bolus dose would be dangerous. So with these words, I request Dr. Govindasamy to take over and deliver the lecture on this World Asthma Day 2025. On to you, Dr. Govindasamy.
Thank you. Thank you so much, Dr. Ilango, sir, my professor. Thanks for the wonderful words. I thank at the outset, I thank the Tamil Nadu IMA for inviting me to speak on this World Asthma Day. So without much ado, I'll go to the presentation. Today's topic we are going to talk about is asthma. So myself, Dr. Govindaswamy, I am a consultant pulmonologist from Tirupur. So with the basics, touch on basics, what is asthma? So it's a definition as per GINA 2025. It's a heterogeneous disease and it's characterized by an airway inflammation with history of respiratory symptoms like cough, wheeze, shortness of breath, chest tightness. And the recent 2025 guidelines has changed the way. Important point here is variable expiratory airflow. Previously, it was limitation. Now it has been removed, and we have gone with came with the variable expiratory airflow itself. So when you see about the prevalence in about world in the last statistical survey about by 2021 is estimated that around 260 million individuals with asthma are living, and they have in India, when we see, it is about the full prevalence is about 3%. That is contributing to about 13% of the global burden of about 34.3 million cases. So when we classify into adults and children, surprisingly, you could see adults have about 2.4% of prevalence, whereas in children it ranges from 4 to 20%. So that's how the morbidity and mortality here. So some common triggers for asthma are irritants like air pollution, environmental pollution, viruses, and the majority, about 80%, are about allergens. It comprises of both outdoor and indoor allergens. When we see about little bit about pathogenesis, so asthma, an allergen comes and it gets presented itself to the dendritic cell, from where it gets presented to the type 2 helper cells. Once it has been presented to the type 2 helper cells, it goes through a two mechanism. One is it activates interleukin 4, and other is it activates interleukin 5. So once interleukin 4 is activated, it coats the mast cells and releases the histamines and leukotrienes, which are inflammatory mediators responsible for asthma. The other pathway is through the interleukin 5, where it activates eosinophils and releases cytokines and leukotrienes, which in turn causes airway inflammation and bronchial hyperresponsiveness. So when we see about the airways, it is a normal airway and it is an asthmatic airway. So in a normal airway, we could see the air caliber moving freely, but in a remodeled asthmatic patient, we have mucosal hyperplasia, we have distorted epithelium, we have bronchoconstriction. So with this in mind, a short bit about symptoms, because we need to have a proper history and examination before confirming the diagnosis of asthma. So that's why I put up these slides. The majority of the people have these 4 classical symptoms, which have cough, wheezing, shortness of breath, and chest tightness. See, these 4 vary in intensity according to the day. It has nocturnal variation, and more in the evenings and more in the early mornings and the night. So coming to the diagnosis part and treatment, which is major for this day. So this is a flowchart provided in GINA 2025 that is released today. Any patient you see with chronic recurrent respiratory symptoms, you just ask the question, are the symptoms typical of asthma? If the answer to the question is yes, you have a detailed history and an examination, and both of these support a diagnosis of asthma. And if you have a spirometry, if you do not have a spirometry, the next best tool is to have a peak flow meter. You check the peak expiratory flow. If both are available, you go ahead with it. So if you perform a lung function test and you expect a bronchodilator responsiveness, that is the reversibility, you confirm the variable expiratory airflow, then you label the patient as asthma and you start the patient on ICS, that is inhaled corticosteroid containing treatment. If you do not have a spirometry or a peak expiratory flow, consider biomarkers like blood eosinophils. And if this history, clinical examination, blood films are suggestive of asthma, you start the patient empirically on ICS containing treatment and review the patient. And when you have a PFT or a spirometry available at you, you can do the test and confirm it, because confirming is important, because labeling a disease is must as foremost. And if you don't have any symptoms or history that is suggestive of asthma, you look for an alternative diagnosis. So important slide for this whole session is this. Everyone has to know about what is a spirometry with bronchodilator response, because this confirms the diagnosis of asthma. So know these two values in any adults. When you do a spirometry, and if you see an increase from baseline in FEV1 or FEVC of about more than 12% and 200 ml, make sure that it is both. You should have a percentage change of about 12% and 200 ml, or if you are using a peak flow meter, then you have a change of about more than 20%. The same in case of children, you have an increase from baseline from FEV1 of about 12% or more, or in a peak expiratory flow of more than 15%. So when we look at the diagram, so this is the flow volume loop and it's the time volume loop. So when you see, this is the normal FEV1 curve. So at the end of 1 second, this is how a normal person can blow. Can you see? This is the asthmatic patients, and a bronchodilator response shows an improvement in curve. So this is what we elicit, we see in a asthmatic spirometric chart. So always look at the chart rather than the values, because once the chart is better, you can interpret. If the chart is not better, the flow on the curve is not good, then we need not interpret the reports at least. This is important. Another important is this is the normal flow volume curve. Can you see, this is called the scalloping or scooping of the flow volume curve. This is classically seen in obstructive airway disease, asthma, and you can see a reversibility. After giving an inhaler, you see an improvement in the flow volume curve. So other diagnostic modalities are radiological imaging like X-ray or CT, which will show you a hyperinflated chest, air trapping, mosaic attenuation, and some extra causes like ABPA features can be seen. And mainstay in the asthmatic diagnosis is lung function test, either by peak flow measurements, spirometry, and in some rare cases, bronchoprovocative test. And as recently, FeNO has come into play. An allergy testing for allergic type of asthma, we have skin prick test or blood allergic test. So blood eosinophil count, total IgE count, as well as specific IgE will help you in narrowing down the diagnosis. So another important point in asthma is clinical phenotypes, because there are a lot of phenotypes in asthma. Then each individual phenotype has a different type of treatment approach. So the majority is allergic asthma, where it is mostly eosinophilic airway inflammation. It responds best to ICS. The other is asthma with persistent airflow limitation, where the airways go for remodeling and become fixed on a chronic period. The other important is non-allergic asthma, where it is more of neutrophilic or a passive granulocytic asthma. They have a poor response to inhaled corticosteroids. The other is cough variant asthma, where the patient typically says only a cough, no wheezing or breathing difficulty. And we even do a PFT, it may be sometimes normal. Provocative tests can give a good diagnosis. The other important one is asthma with obesity. The other is adult onset asthma. It is usually a late onset asthma, mostly seen in women. They also have a poor response to ICS. So coming to the treatment topic proper, we are going to the treatment of asthma. So I know you have been, you're all been well aware of these terminologies, but before going to the topic, I need to just stress upon few things. ICS is inhaled corticosteroids. SABA is short-acting beta-2 agonist. SAMA is short-acting muscarinic antagonist. LABA is long-acting beta-2 agonist. LAMA is long-acting muscarinic agonist. So till 2019, what GINA or previously we followed is any patient with intermittent symptoms, you use SOS SABA as reliever and no control is required. Any persistent symptoms, a patient with persistent symptoms, we used still SABA as a reliever and ICS or ICS LABA as a controller. With moderate or severe symptoms, we had a LABA as a controller and we have added ICS formoterol as a reliever. This is what happened till 2019. What happened in 2019 is, based on all these things, we wanted to shift from a SABA to an ICS LABA combination. So giving SABA alone as a reliever has several disadvantages. What are those? Patients with apparently mild asthma are still at risk of serious adverse events. The exacerbation triggers are many and they are unpredictable. Starting treatment with a SABA trains a patient to regard it as their primary asthma treatment. They get relied on it and it is difficult to switch them from a SABA to a normal inhaler. So a regular use of SABA, even for about 1 to 2 weeks, is associated with adverse events like beta receptor downregulation, rebound hyperresponsiveness, decreased bronchodilator response, and increased allergic response. These are the important factors which played an important role in shifting the SABA alone reliever to ICS LABA reliever. So higher use of SABA is associated with adverse clinical outcomes. So dispensing of more than 3 or equal to 3 canisters per year is associated with higher risk of severe exacerbations, and dispensing of more than 12 canisters per year is associated with much higher risk of death. So do you have patients who use only SABA for the asthma treatment, or do you prescribe only SABA to your patients? If the answer to these questions is yes, it's time to change. Do not prescribe Astelin or Livolin or Duolin alone to a asthmatic patient. That is take-home message here. So this is the paper which changed this shift. It's published in 2019. Every patient of asthma should be prescribed an inhaled corticosteroid to prevent symptoms. The other important point is, in case of symptoms, the choice of reliever drug is always a combination of an ICS plus SABA or ICS plus formoterol, that is air therapy, that is anti-inflammatory reliever. So ICS formoterol is a mainstay of treatment. Avoid prescribing plain salbutamol, levosalbutamol, or ipratropium salbutamol as a reliever to your patients of asthma. So what are asthma, no activity limitation, no. This is what GINA 2023, from GINA 2023, we have recommended 2 tracks for the treatment. One is track 1, that is a preferred one. The other track is alternate therapy. So where the reliever is the next slide, next click, sir. So reliever is used as an SOS ICS with LABA, that is ICS with formoterol, where in track 2, the less preferred one, the next one, the reliever is SOS ICS plus SABA. There also ICS is insisted. Next one, sir.
எப்பவுமே மியூட்ல தான் இருக்கணுமா அது?
நம்ம பேசுறது
Is unwilling for track 1, you put the track 2 option.
அன்மியூட்னா நம்ம பேசுறது கேட்கணும்.
Next, sir. Next slide, sir. So this is how it goes. The track 1 is consists of about 5 steps, back steps. So these are the inhaled steroids we currently use. That is budesonide, fluticasone, propionate, beclomethasone dipropionate, cyclizone. Most common we have is about budesonide, methasone, and fluticasone. Next, sir. The key points to remember before stepping up the dosage is confirm that the patient is adherent to the treatment and it's not missing out on the dosages. Confirm that the patient is using the inhaler with correct technique. The next is ensure that there are no comorbids like allergic rhinitis or GERD. Ensure that no environmental triggers like exposure to cigarette smoke, indoor and outdoor pollution, air pollution, and damp walls are not present. Next, sir. So, as such, Gina, this is the important cycle for the management. Anytime you assess the patient, adjust the treatment, and always review the patient again in a short intervals. And based on the response, we again assess and adjust the therapy. Next slide, sir. So I'll go to a case study. There is one case one where a patient of about 45-year-old lady brought to the ER at 4 a.m. with breathlessness and wheeze. She is restless, sitting bent forward, and cannot complete sentences without stopping in between for breath. This is her third such episode in the past 1 year. In between these episodes, she has cough, chest pain, chest tightness, and breathlessness on exertion and climbing up stairs. In presence of strong smells, smoke from cooking, dusting the house, tobacco smoke, change of weather, and remains fairly asymptomatic during summers. Next slide, sir. On examination, evidently breathless, pulse is about 100 per minute, BP is 130/90, and respiratory rate is 20 per minute, and SpO2 of 94%. On respiratory system auscultation, the patient has bilateral bronchi. This is the management given in the ER. O2-driven nebulized bronchodilators and steroids, that is oral steroids of about 30 milligrams stat, and hydration. The patient got settled in 2 hours. Next, sir. Sent back home with the treatment. So treatment on discharge, tablet prednisolone 30 milligram on tapering doses, and tablets salbutamol 4 milligram TDS for 5 days. Salbutamol inhaler about 2 puffs 4 times a day for 15 days. And patient is asked to review after 7 days. Do you feel, is this good? Obviously, this is not the correct, proper way for treatment. So the patient is referred to us. So next slide, sir.
Maybe that
The
is
patient
over treatment, sir. Maybe a over treatment.
Yes, sir. The patient was referred to us, sir. We took a thorough history, performed a spirometry. Can you all please interpret the spirometry report? The next slide, sir. See, focus on the graphs first. You can look at the flow volume loops. So what it says is this patient have asthma or not? You can put some answers in the chat box. Okay, owing to the time, I'll just go ahead. So thing is that when you look at the graphs carefully, it shows an obstructive pattern. The FUN by FEC. Next, sir, it is about 0.46. Next, click next, sir. It'll click circle. So 0.46. And the next, when you see the FEC, it is about 71 pre, that is 2.59, and it is changed to 3.56. So at the end, we could see there is about 480 ml of reversibility with 41% change. So that is definitely classical of asthma. So this patient has severe asthma. Next slide, sir. So this shows airway obstruction. So which track will you choose? And which step of treatment will you start? So this is track 1 and track 2. see, always choose track 1. And if you could not do, then you can choose track 2. So I'll choose track 1. And based on this, the patient has step 4 treatment. Next slide, sir. Click next. Sir. Okay. So track 1, the patient has been given on formoterol budesonide, that is LABA with ICS, 200 micrograms, 2 puff twice a day. And as SO is also, reliever also given the same as smart therapy with a spacer, which is non-static, walled and transparent, given an advice of gargling after inhaler use and avoid exposure to pollution, strong smells and tobacco dust. So this patient is asked to review after 1 week with medicines and devices. This is how this patient is solved. Next, sir. She came back within 15 days with an exacerbation. We checked her technique for using the inhaler. Next slide, sir. Sir, can you play the video, sir?
Video.
Down. Down, sir. Click the play button, the video.
1 second. Sorry, it went off. Yeah.
So everyone can see this patient as she okay. So can you see the patient? The thing is that this patient doesn't take the inhaler properly. So she just actuates 2 puffs simultaneously and she does not breath hold and she's just blowing out.
Hello?
So this is not the proper technique. When you teach the patient correct technique, the recurrence and exacerbation comes down. Next slide, sir. It's a short case. Next, sir. A 37-year-old guy, a known case of asthmatic for the past 4 years under treatment with chest physician. He was referred to us with repeated episodes of breathlessness and wheeze 3 times in past month. Has woken up from sleep because of symptoms. Feels better after taking his SABA. Is currently on salmeterol fluticasone, that is LABA ICS, 125 micrograms, 2 puffs daily with an MDA. Next, sir. Is his asthma well controlled? So what is uncontrolled asthma? So we have to ask all these questions to the patient. If the patient says no to everyone, that is controlled. If he answers more than 2, then it becomes uncontrolled. So 3 or 4 becomes uncontrolled. Sorry. So this patient we saw already. So he gets ticked for 3 out of 4 options. Next, sir. So yes, so 3 or 4. So this problem adherence is good. We check the inhaler technique, all is good, but we missed one. The previous physician missed one. What is it? Next, the device technique is also good. He works in the municipal corporation bus depot. Next, he has associated allergic rhinitis. We managed allergic rhinitis with intranasal corticosteroids. Now the patient is all fine. So always treat the comorbids. That will help in a lot. Next. So remember important things. And the advantages of using inhaled medications is always you have to stress upon. Need to continue the inhaler medications even the patient is well controlled and asymptomatic. It is not like SOS. Regular follow-ups are very important so that we can gradually step down the patient's therapy and maintain the patient on lowest possible dose of the inhaler. Next, sir. The major investment you need to do to manage your asthma patients is spend your time with them. It will definitely give a better patient satisfaction and prevent repeat visits and certainly give you more patients. Next, sir. A single slide to touch upon other aspects of asthma management. For step 5 and for higher center management, we have biologicals and namely quite anti-IgE, omalizumab, anti-IL-5 and anti-IL-5 receptor antagonists like mepolizumab and bendalizumab, and IL-4 RA antagonists like dupilumab, and anti-TSLP tezepelumab. These are all approved for treatment in asthma. And for few cases, the bronchoscopic management of asthma is bronchial thermoplasty. It is a grade B evidence. Although long-term trials are not effective, the few subset of patients better work good with this bronchial thermoplasty. The age-old is allergen immunotherapy. This has been approved and it has been proven effective in case of allergic asthma and prevention and treatment. The other important aspect is vaccination with RSV, Tdap, shingles, influenza, pneumococcal also help in bringing down asthma exacerbations. So last but not least, what I want to stress upon is inhalers are the best modality for treating asthma. Inhalers are very safe. You have to stress upon it and always stress about making a diagnosis by making a PFT or a spirometry. Thank you, sir. Thank you.
Thank you, Dr. Govindasamy, sir, for the excellent presentation. Dr. Ilangovan, sir, please give your comments, sir. Then we'll go to the next question from the participants.
Correct. I do apologize for the problem which happened in between because there was a probable Wi-Fi problem. But this is an excellent lecture by Dr. Govindan. And the crux of the talk was that we switched from tablets to inhalers. If you saw the slide of the first case report, he showed a tablet salbutamol was written. Though it comes very low down in the guidelines, never use tablet salbutamol. And as I told you earlier, never injection deriphyllin. Injection deriphyllin has been replaced by nebulizers. So I just opened the floor for questions and answers before going on to the next talk.
Dr. Govindan?
Sorry.
Yes,
Hello?
sir.
Yes, sir.
Only one question regarding the asthma diagnosis and treatment. I think we are over-diagnosing and under-treated. Is it right?
It's not the same, sir. It is mostly underdiagnosis than over treatment, sir.
இல்ல அவங்க வீஸ் எல்லாம் கூட எல்லாத்தையும் சேர்த்துறாங்க. Any simple வீஸ், simple
I'll just chip in. Sir, from the view of a general practitioner and even consultants, not pulmonologists, I agree with over-diagnosis.
Yes, sir.
They're bringing in COPD along with asthma. The treatment for COPD is different from asthma. So
exactly.
See, if you look at Dr. V.K. Vijayan's landmark paper on the incidence of asthma, it was said to be at 2.54. This is in 2005. And later on, more or less, it remained at 2.5%. But even that, I'm not very sure because of logistics of the finances involved and the support that Dr. V.K. Vijayan gave. By the way, Dr. V.K. Vijayan was the greatest respiratory physician of India, with the maximum number of academic publications, and who was my thesis guide and ultimately became the director of Vallabhbhai Patel Chest Institute. So you look at the incidence, is asthma about 2.54 and COPD came at 6%. So the COPD is clubbed along unless you know how to segregate the asthma and COPD. I agree that they all they get treated and the treatment is highly under. I totally agree with sir that there is very under treatment. We have to switch to inhalers and to nebulizers therapy.
Exactly. Only one last question to Govind.
Yes, sir.
Refractory to treatment asthma, is it common nowadays or less?
Sir, the actual prevalence quoted in studies it points to about less than 5% to 3% of whole asthma cases, sir. It is the proper inhaler technique, proper diagnosis, and proper treatment brings down the severe refractory cases. We have to look for the comorbids. We check the comorbids, treat the comorbids, and underlying problems has to be solved. Despite all this, if it comes, still the prevalence is too low, sir. And we have certain therapy for severe refractory asthma too.
Thank you. God bless you. Thank you.
I totally
thank you.
Agree with Dr. Govind. And if we know how to use inhalers and nebulizers at the outpatient department, patients who are very sick they are switched on to biologicals, which are very costly and very dangerous, and still in the experimental phase. If you know how to use nebulizers, especially in people with cardiac arrhythmias also, with ectopics, put them on a Holter monitor and adjust your nebulizer therapy, you will never go in for biologicals. I have never had a single patient who I could label as refractory asthma or resistant asthma because I knew how to use nebulizers, left, right, front, and center. So nebulizers are the key. We learn how to use them properly with the proper precautions, especially in cardiac arrhythmias. Then this issue of asthma resistant or refractory will never happen in general practice.
Thank you, Elango. Thank you.
There is a chat box question. Use of Montelukast for how long?
So I take a question. The Montelukast is not so recommended for asthma treatment. It is an adjuvant therapy recommended for asthma and for allergic rhinitis. There is no clear-cut indication that you have to prolong the use or minimize the use. As long as the patient has a symptomatic control, you can use Montelukast. Although very, very few incidents of adverse effects have been reported in Montelukast.
Okay, thank you. Amal Johnson. Dr. Amal Johnson has asked one question. Current use of ultra bronchodilators in asthma. Ultra bronchodilators.
Definitely, sir. Ultra-fine, ultra bronchodilators are recently come into practice with triple inhaler therapies. So they are the next major breakthrough in asthma treatment and as well as COPD treatment. The recent launch of triple inhalers like omeclinium based Belenchol fluticasone has shown a promising treatment response in asthmatics, severe asthmatics who are not treated adequately controlled with high dose ICS. So they make an important role in our new treatment protocols.
Thank you, Govind Swami.
Govind Swami, I am Dr. Chokkalingam.
Yes,
I
sir.
really appreciate your nice talk and how Ilango moderator. Really happy.
Thank you so
Only one
much.
small comment. There are some occasions
Yes,
where
sir.
there will be overlapping of both cardiac failure and non-asthmatic. Then becomes difficult to treat them. So one must approach in both the ways. But many of my
Yes, sir.
patients, they come to me, cardiac failure as a non-asthmatic for many years being treated. Then they diagnose cardiac cause for the asthma. There's a cardiac asthma for left ventricular failure, left heart failure. So one must be all the time give importance to segregate the two entities, and there may be possibility of overlaps, and one must be very careful. But excellent presentation, Govind Swami. More so, Ilango and moderated so nicely. Thanks to everyone.
I totally agree
Thank
with you, especially in elderly patients who are known asthmatics with you for 20 years, and they come with an exacerbation. If they have underlying hypertension, diabetes, and a question mark history of CAD, please take a ECG and take an echo, do your TROP-T or send to a cardiologist, because they could be having not an acute asthma attack, they could be having what sir said as cardiac asthma, they may be having a silent MI and going in for LVF. We have lost a lot of patients who have died because they have not been given cardiac treatment. Chronic asthmatics who develop an MI or an angina are missed in general practice and even in consultant practice. So this is a very important thing sir has brought out. Be careful about that. Yep.
So one more word, Professor Chokkalingam used to tell us in the class about renal asthma is a third entity. I think in 79 classes, he used the word renal asthma.
Because there is a cardiorenal syndrome, the cardiac and renal are interdependent. Anyone they go for, then anything that produces wheezing, we call it as asthma. But as they are pulmonologists, how they are deal line, there's two entities, and one must be very careful. And thank you for remembering my classes. Very so happy. And recently I went to CMC Hospital. I'm visiting professor to the CMC Hospital. 2 weeks back when I took a class, one student, lady student named Pramila, and she stood up and she told me, Ilango, my grandmother was my student. Her name is Bhanumati. So now I am taking the third generation. I was telling that student, I may be even taking class for your daughter if I am still existing in the world. So there is a teaching I love is going on like that. I really appreciate Sendil for this excellent platform creating. Thank you,
Thank
Senthil.
you, sir. Thank you, sir. Thank you, sir. Sir, there are some questions in the chat box.
1 second. Oh, you want to check
Sir?
the chat? No, I'm
Yeah,
checking.
yes,
Yes, sir.
yes.
Role of
Senthil
oral
sir,
steroid
Role
Senthil
of
sir,
treatment.
steroids in
வேண்டாம்.
the,
Yeah.
செந்தில் சார் வேண்டாம் போதும்.
Okay.
Oh, no more questions
okay.
from the audience? Is that, I mean, no more questions from the audience?
Chat box, that's all, sir. Chat box question almost we answered.
Chat box, I
Okay, sir.
see anything.
Look out everything, sir.
Dr. Govind, would you like to say anything before we wind the session?
Take home
Nothing,
message.
sir.
Take
Only
home
Take home
கொடுங்க.
message, sir. Moderator, sir. You have to give your take home message to the participants.
Giving my take home message. Yes, sure. But Dr.
Yeah.
Govind
So only 3 points, sir. 3 points I would say. Always to establish a diagnosis of asthma by doing a PFT or simply use the peak flow meter. Second is always spend time to your patients, explain the need for using inhalers, the first treatment option for asthma and the only treatment option for asthma. And avoid intravenous deriflins and oral deriflins and salbutamol as much as possible. We could say, I would say, contraindicated to use. Thank you, sir.
Okay, I'll just wind up a few minutes. I was one of the early founder members of Apollo Hospital, main Chennai, Greaves Road. One of the early members of the ethics committee. So I was a very stringent ethics committee judge. So I was kicked out after about 10 or 15 years because it was too strict, not allowing international trials to come in. And I was one of the early international trial administrators and physicians, the primary physicians for important trials like meropenem, inhalers, and intravenous fungal antibiotics like micafungin. So I was in touch with the US FDA and we were knowing what was happening. What I'm trying to tell is the GINA guidelines for asthma or the GOLD guidelines for COPD, the persons who are funding it are the pharma. It is not any government which is funding it. The GINA guidelines are funded by the topmost pharma companies in the world, GlaxoSmithKline and all the topmost Pfizer. And you know, after the COVID, what happened? So all these guidelines have to be taken not with a pinch of salt, but with a tablespoon of salt. So when you have these guidelines, just follow them. One example I would like to give is what Govindasamy said that for SOS, whenever there is an issue, you give a salbutamol nebulizer. But now they have switched on to formoterol. But in my experience, formoterol is dangerous as a reliever. Though they have support studies, I think it is more because of the pharma push. So it is always safer to use levosalbutamol rather than formoterol. So what I'm trying to tell you is take all these guidelines with a pinch of salt. The next one is the peak flow meter. For those who cannot afford pulmonary function testing, or if you have a bedside peak flow meter and learn to use it, the guideline values are 320 to 420 for women and 420 to 620 for men. And anything which falls less than 250 in male or female is dangerous. That is the peak flow meter as a bedside tool companion. And learn to differentiate between asthma and COPD because the treatments are different. Any history of allergic rhinitis, sneezing, running nose, or allergic dermatitis with the person with breathlessness, asthma is in. You need not have a pulmonary function testing. I'm not talking from GINA guidelines. You have an allergic diathesis for a patient and the patient has breathlessness, even if the chest is clear, ask the techniques of dynamic auscultation, which is ask the patient to cough. When the patient coughs, if the patient gets wheeze, or on forced exhalation, if the patient gets wheeze, patient has got asthma. Another things, please use steroids very freely, especially in children, because children, morning 10 o'clock when they have wheeze, by 12 o'clock, if they don't get a nebulizer, by 2 o'clock, they can land on the ventilator. So use high dose steroids, 40 milligrams of prednisolone or methylprednisolone for 5 days, maximum up to 21 days without a cutoff. And I've already told you about formoterol and steroids. And again, I'm telling, in children, asthma treatment has to be at a very fine-tuned basis, and they have to be taught about peak flow meters and maintaining peak flow meter diaries. And in people who are giving inhalers and nebulizers, watch out for ectopics, cardiac arrhythmias, do a 24-hour holter before doing anything with them. And I would like to tell the association people that when general practitioners are in tandem with pulmonologists and you start treating along with them on a long run, then you start learning pulmonology, and over a period of time, you will not be dependent on pulmonologists, but you will start learning as a general practitioner how to use inhalers and nebulizers, where your quality of control on your patients will be 100%. And what Dr. Jayaraman said, that all that glitters is not gold. If we go into that topic, that is another 1 hour lecture, like cardiac asthma and renal asthma, where there is a peribronchial cuffing of the pulmonary edema producing the wheezing. We have a lot of other conditions which may mimic, especially upper airway obstructions. And we have psychogenic asthma and stuff like that, especially upper airway obstruction can mimic as asthma, renal asthma, cardiac asthma. Be careful about it. Another thing important in the emergency in your clinic when you are dealing with an asthma patient, especially children, even the peak flow meter may desert you in knowing the severity of the symptoms. As said in Crofton and Douglas, the best indicator for impending respiratory failure in a child especially is the child giving up to breathe. When you see the child breathing heavily, you are sad that the child is breathing heavily and in dyspnea. But the moment the child gives up, the patient is going to go for hypercapnia. So the child or the adult giving up in an emergency or in your clinic is the first sign of impending hypercapnic respiratory failure. So be careful about that. The most important thing what Dr. Govind had said is spend time with your patients, peak flow meter, educating them with the spacer device. No inhaler should be given without a spacer device, and giving them a peak flow meter diary and seeing them every month to check with the peak flow meter diary. Because if you Google in GINA, you'll get the peak flow meter diary with traffic signal zones, green, orange, and red. That is very important. And coming to last 2 points, biologics. I have never used a biologic in my life. With nebulizers and inhalers, you can tide over. Vaccination, question mark. Flu vaccination, most respiratory physicians do not do it. I was scared during the COVID epidemic. During 21 and 22, I think I took 2 shots, but now I'm not taking flu. That's it for vaccination. And I now hand over, thank one more time, Dr. Govind and the IMA for this excellent session during World Asthma Day, especially when our professor and guru is already there for the next session. I hand over the mic back to sir. Thank you.
Yes, sir. Jayaraman sir, shall we go to the next session? Jayaraman sir? Jayaraman sir?
Sorry, go ahead.
Yes, sir.
Sir, go ahead.
Sir, thank you very much, Dr. Govindasamy sir. Oh, sir. Thank you very much, Dr. Govindasamy sir and Dr. Ilango sir for the excellent session. And we'll move to the next session. Govind sir, kindly stop sharing the screen. I'm going to share the screen. Now the next session is the hypertension update. First, introduce this speaker, Dr. Cecily Majella. She is one of the rising star of cardiology in Tamil Nadu. She studied of Medical College. I'm happy that I am the classmate of Dr. Cecily Majella. She received the best paper award at ESC Congress 2023 by the ESC president. She received International Best Paper Award for Cardiology in 2018 at World Cardiology Congress by American Heart Association president. She received first prize for the best challenging case in the Asia Pacific Vascular Interventional Council in 2017. And she received DP Basu Young Award in Cardiology and first place in oral presentation in Indo-Japanese CTU Summit. She received the award in 2023 by the Raindrops Association. She is the first in more than 30 chapters in various textbooks of cardiology. She is the author in 14 international and 30 national publications. She presented more than 100 presentations in various international and national conferences. And the procedures are more than 6,000 angioplasties and more than 15,000 angiograms and 300 pacemaker insertions. I think she is the best speaker. I'm going to speak about the hypertension update. And at the same time, I'm going to talk, I'm very glad to introduce Dr. V. Chakkalingam. She is the brightest scholar of cardiology in Tamil Nadu and all over the world. and the professor of cardiology in Tamil Nadu MGR Medical University in Chennai, and former director Institute of Cardiology, Madras Medical College, and chief cardiologist, Government General Hospital Chennai. She won the gold medal in medicine in MBBS and MD, as stood with the first rank in the both at the state level, and also the gold medalist in DM cardiologist with the first rank at the national level. She was the first graduate as a DM cardiology from Madras Medical College, Chennai. She was the recipient of International Award of Excellence in Cardiology by the World Congress Cardiology. She has been practicing cardiology, teaching cardiology for the undergraduates and postgraduate students of medicine and postgraduate doctorate students of cardiology. She and examiner for the 56 years. He has published and presented more than 100 scientific papers, national and international cardiology conferences and journals. Many books like Idayam Kaka and Humor and Health in Phil and in more in international mind recall and journey to the heart health and the cardiac exercises. He is a strong believer that heart attack, the number one killer of disease, can effectively and prevented and cured by the implementation of positive lifestyle. Awareness, he regularly appears on several social media, television channels, all-day radio, and reaches out to the public through print media. He is a speaker at the international media meetings and regularly addresses mindset and lifestyle enhancement at public gathering. Has been எல்லாராலும் இதயம் காக்கும் இதய மருத்துவர் என்ற அனைவராலும் காக்கப்படும் டாக்டர் வி சொக்கலிங்கம் அவர்கள் இந்த செஷனை மாடரேட் செய்ய போறாங்க. Over to Dr. சொக்கலிங்கம் சார்.
I am really honored. I am very thankful to everyone and the great opportunity and the platform given by Sendil Kumar and his team. I am so happy to see many students, and really they're all excelling Chokkalingam. I request you to allow me to share my slides. Shall I? Okay. I hope you all can see that.
Yes, sir. Yes, sir.
Very good. Now, today I am completing 8 years of my age, and I am nearing 60 years of my cardiology teaching. And any queries, please be free in asking. Along with the Majila, I will like to take part. About 25 years before I wrote this book on Mind and Heart, published by Elsevier, it has been known and then read by millions of people. And I would like to ask you one question. We are all from one evolution theory by rhesus monkey. There is a reason why our blood groups are all RH always. So monkey has rhesus one only has got plus and minus. The first human being, when he had life, he had only A plus and minus. The next, after millions of years, B and then AB. A last one to develop is the O plus and minus. After million years, new groups will be added. I'm not sure about it. I want to ask you, anyone in the platform, if I want to choose the best blood group, which one you will choose, Sendil? Among A, B, AB, O, which one will be best blood group? Yes? Unmute and answer. Majila, you also can answer. Which is the best
AB
blood
negative,
group?
sir.
Eh?
Sir, I am Dr. Jamil, A group, sir.
A group. Many will say O group because they are all thinking the universal donor is true. But only thing, let it be any blood group. I request those who are all attending here must be B positive, not in the blood group, in their attitude. The moment you are going to have the B positive attitude, and then you will be free from any diseases. So how many hearts are there? Please tell me. Right or wrong, please involve in answering my questions. How many hearts are there? Fast. Yes, Sundaramurthy, Sendil, Ilango, over.
One wife, one heart, sir.
Sir, very young, sir. Male and female, very young, sir.
Okay, everyone knows there is one heart which I have been teaching for the last 60 years. Please remember, there are 3 hearts God has given you. The 3 hearts, what you mean is, the peripheral 2 hearts are the calf muscle, right and left are 2 hearts. Human beings are meant to be dynamic, either sitting, standing, walking, jogging. Then the blood in the legs will pump and it will be reaching the heart, and the heart will work nicely. So please, you all the time work to the calf muscles. So this heart will be healthy. I want to ask you, you know that 72 minutes, 1 lakh time per. Suppose இதயம் பேசுகிறது. இதயம் பேசினால் அது என்ன கேட்கும் உங்களிடம்? சொல்லுங்க பார்க்கலாம். செந்தில். Very short, 5 minutes I want to finish.
எனக்கு ரெஸ்ட் கொடுங்கன்னு கேட்கும் சார்.
ஓ, ரெஸ்ட் கொடுன்னு கேட்டா நம்ம இறந்துடுறோம் சுந்தரமூர்த்தி.
சுந்தரமூர்த்தி சார் ஒரேடியா
போயிட வேண்டியதுதான். ரெஸ்ட் கேட்கக்கூடாது.
ஷார்ட் டேர்ம் ரெஸ்ட். ஷார்ட் டேர்ம் ரெஸ்ட்.
இதயம் கேட்ப நிறைய பேர் சொல்லுவாங்க எக்ஸசைஸ், டயட்டிங், எவ்ரிதிங். ப்ளீஸ் ரொம்ப இதயம் கேட்பது ஒன்றே ஒன்று, மகிழ்ச்சி மட்டம். The moment you are going to smile and happy, heart will continue to work more than 100 years. So success is not the happiness. Please remember, happiness is the greatest success. Happiness, how will you get it? Only by means of in giving. Much more happiness, can anyone say? Giving is happiness.
Service.
Service is happiness. What else? Right or wrong, please answer. So giving is happiness. Manifold happiness, then giving is what?
Sharing.
Please remember, forgiving is the one. The moment you have got the mental attitude of forgiving, no problem at all. So ultimate wealth is the health. That is what health is wealth. Please remember, there is World Heart Federation and WHO redefined health. That is a positive state mentally, physically, spiritually, and socially. Our ancestors all put together as a holistic. They include the mind, body, soul. You won't believe, Sendil, 20,000 years ago they have given this greatest medicine, that is yoga and meditation. You have come out far away from that. There is a reason why you all became victim of all diseases, including asthma, heart attack, cancer, accidents, everything. So please be all the time. This is very important because in America, Europe, and Canada, the physician burnouts have become very, very common. Please be very clear. That too, suicidal tendencies, depressions, or maximum victims are all doctors, more so cardiologists. So yeast is natural. The moment you dispel the yeast, we call disease. So the disease, all diseases start from mind, body, in Latin psychosomatic. So largest endocrine organ, which is the one you all guess? Can anyone? Which is largest endocrine organ?
Liver.
Liver. Right or wrong doesn't matter. They must involve in answering.
Pancreas.
As?
Pancreas.
Pancreas, fat, skin. Please remember, the largest endocrine organ is the endothelium lining the blood vessels. Why I'm saying this, the length of blood vessels in a human being of 6 feet, it is 100,000 kilometers. So our endocrine system is 100,000 kilometers, and the number of cells in a human body of adult one is 40 trillion cells. So each cell is an organism. And please remember, the endothelium that is lining the arteries constantly secrete lot of hormones to make it function or go for dysfunction if it's going to be. The same thing is true for any system. So the unfortunate thing, even though you have been talking, maximum heart attack, stroke, hypertension, diabetes are all maximum in Indians, sometimes more than Chinese, 20 times than Japanese. The most important thing I want to stress, please remember, every an hour, 90 people are dying between the age of 20 to 30, both sexes. Most hypertension, diabetes, stroke, or any cardiovascular diseases. So sudden cardiac death is very common. If you're going to have 100 patients, hypertension, diabetes, infarction, the 30% of infarctions, they don't reach any hospital. The sudden cardiac death within 2 minutes, the only because of electrical failure, and that can be prevented only by primordial and primary prevention of it. So negative lifestyle, please remember that the attempt to take with the depression, more of fatty, increase of weight, smoking, they think that sedentary life, smoking and alcohol, and that only leads, please remember, cholesterol, sugar, and pressure, and results in the block of it. and your children will follow that. The negative lifestyle is the one pay way for all the diseases. That's what I would to say. The metabolic syndrome of obesity, dyslipidemia, diabetes, and hypertension all will go together, and they are joined together to kill us in all the diseases it will produce. Please remember, white coat hypertension, everyone know about it. You must give some time. And now the recent, what is this blood pressure? We see 90/60. How will you label that individual, Sendil?
Sir, hypotension, sir.
Hypotension. It is not hypotension. It's lower limit of the normal pressure. Only when systolic less than 90, diastolic less than 60, then only you call it as hypotension. So the person who has been having this pressure, they have found that they live longer. Tokeling blood pressure today is 104/70 only. The reason at the age of 80, I have never taken even a single tablet. So I want everyone must educate our people how one can be Maranilla Maruthuvam. So please remember the recent concept is any patient on any pressure, you must take one blood pressure in the standing because of we must know orthostatic. Now the recent concept is orthostatic hypertension. Whenever when they're standing up, when the pressure goes up, they're very, very vulnerable for cardiac and cerebral. So please remember, one must take blood pressure in standing after 2 or 3 minutes. The acute negative stress, you know that, Dr. Sobo, and angina may persist after stenting a bypass because of type of personalities, because of hypertension, diabetic, that is known as syndrome X or microvascular. So I want to ask you one question to my colleagues. If going to divide the happiness 0 to 10, which level of happiness you are all living? Be frank in answering which level. 0, no happiness, 10 is good happiness. Which level, Sendil? Or anyone?
Around
Yes.
5, sir.
Yes?
5 is optimal, sir.
How much?
5 is optimal, sir. It's your source green color.
Okay. Now I'll tell you, anyone telling less than 10, even if they say 9, they are prone to get infarction. Don't think I'm frightening you. That what you are mentioning, 3, 4, 5, is external happiness. So what I'm now dividing happiness is external and make the internal happiness உள்ளே போய் அந்த மகிழ்ச்சியை 10ன்னு வச்சுக்கணும். So all the time you be happy with the 10 and then try to remove the unhappy status what you are facing with the inner happiness of 10 only. So I'll ask you one question. என்ன ஒரு கேள்வி கேட்கலாம், சொக்கலிங்கத்தை எந்த மகிழ்ச்சியில இருப்பீங்கன்னு நினைக்கிறீங்க? சொல்லுங்க பார்க்கலாம். What level of happiness? Sundaramurthy, Sendil, whoever is there? என் லெவல் எதுல இருக்குன்னு நினைக்கிறீங்க?
6 and 7.
எவ்வளவு? 10. சொக்கலிங்கம் is 11. Why I'm saying 11? The happiness is limitless. With that limitless happiness only we can preserve our most priceless, prestigious life too.
Sir, Ilango speaking, sir. A small query.
Please.
Sir, from day one, I've been watching you for the last, 20, 30, 45 years.
Yes, Ilango.
Your physical figure, the way you speak, and always, talking about Magilchi. இதனுடைய secret என்ன சார்? What is the formula for doing what you are doing?
Very good. Excellent. இளங்கோ
எல்லாரோட கேள்வி ஒரே கேள்வியை கேட்டார் சார்.
அதே ஒண்ணே ஒண்ணு சொல்றேன். இளங்கோ and those who are here, நீங்களே என்னுடைய students.
Yes, sir.
Now today Choklingam is attending as your student and I want to learn. I want to share whatever thing. நான் ரொம்ப ஏழையா இருக்கும்போது மகிழ்ச்சியா இருந்தேன், இப்போ மகிழ்ச்சியா இருக்கேன். அன்று ஒரே ஒரு கேள்வி உங்க எல்லாருக்கும் கேட்கிறேன். உங்கள் வாழ்க்கையின் பயணம் மகிழ்ச்சியை தேடியா அமைதியை தேடியா? ஆன்சர் திஸ் கொஸ்டின் இளங்கோ. வாழ்க்கையின்
நான் சொல்றேன் சார்.
சொல்லுங்க இளங்கோ.
நான் வந்து பேசிக்கா லைஃப்ல நிறைய ரிசர்ச் பண்ணிட்டு இருக்கேன், இண்டிவிஜுவலா அட் ஸ்பிரிச்சுவல் அண்ட் சயின்டிபிக் லெவல். என்னோட டெஃபினிஷன் ஆஃப் ஹியூமன் பீயிங் வந்து clothed animal living in a concrete jungle. ஸோ பேசிக்கா அவனுக்கு வந்து கண்டினியூஸ் எக்ஸ்ட்ரெசிவ் ஆனு சார். ப்ரெஷர் பத்தாது சார் அவனுக்கு. ஒரு மிருகம் அவனுக்கு. ஆனா அது முடியாத பட்சத்துல அமைதியை தேடி வரான். அவன் வந்து ஆன்மீகத்துக்குள்ள போறதோ, கோயிலுக்கு போறதோ, அவன் கடவுளை தேடியோ, அமைதியை தேடியோ கிடையாது. சந்தோஷத்தை தேடி கிடைக்கல, டிஃபால்ட்டா அமைதிக்கு வரான். இது என்னுடைய அனுமானம் சார்.
ரொம்ப அருமையான கேள்வி. இளங்கோ, நான் உங்களோட எல்லாம் இருக்கவே தான் சொக்கலிங்கத்துக்கு வயசாகல. அதான் முக்கியமான காரணம். தி மோஸ்ட் இம்பார்ட்டன்ட், வாழ்க்கையின் பயணம் அமைதியை தேடியோ மகிழ்ச்சியை தேடியோ இல்லை. வாழ்க்கையின் பயணமே அமைதியுடன் மகிழ்ச்சியுடன். The moment if you decide to travel your life of journey of life, the happiness, nothing will happen, because once the moment you lose your happiness, you are losing your life. That is the reason why if you are going to be having, I will tell you, give you the tip now recently. So for existence, we need 3 E's: emotion, eating, exercise. I made it as 3 mantras. Please remember, be positive in thinking, healthy in eating, adequate in exercising. The moment you are going to hold all the 3 mantras, we will be disease-free up to 100 years. Not only will be disease-free, any disease will vanish. So never compromise the 3 mantras. Keep it with your life. Please tell all your friends and patients, which I have been following from the age of 20. So the reason why I am now looking at, I will tell you, the biological clock, our age can be reversed by means of 3 mantras. So please remember, positive life, vegetables and fruits, exercise, optimal weight, both passive and active smoking, and we will be surprised, my dear friends, 90% of people after 1 year, they don't need to take cholesterol, sugar, or even blood pressure tablet. They can be free, provided they travel this positive life cycle, and that result in permanent cure also. So please remember, the evolution and creativity, I'm not going to go. 6 million years before that one evolution, our ancestors needed at the time adrenal cortisol or for fight, flight. Unfortunately, today, this person see a team and see this person how they are too only making us more richer. Please remember, less luggage is more comfort, both in body and your mind too. The most important thing I would like to share, cholesterol is a mandatory for living. If you remove the cholesterol from the blood today, all organs say stop it. So as long as the cholesterol within the blood, whatever the type, is going to save us. But the moment you are going to negative stress, adrenal cortisol, cholesterol get deposited. So the only cause the cholesterol is the deposition block is because of negative stress. It will take 15-20 years for the gradual block of it. But acute 20 to 30 years when they are playing tennis, when they are doing gym, or when they are dancing, or any acute stage, we are going to consider the clot occurs, or the vessel goes for spasm, or acute extreme happiness also may be sometimes dangerous. It may produce that. So please remember, be happy and have this dose hormones. That is dopamine, oxytocin, serotonin, endorphin. Endorphin is nothing but a morphine secreted within your body, and melatonin must have it. So one good news I want to share, which has been published 22 years ago, when you are going to have a positive lifestyle, what I have been telling, for 1 year from today, please remember, it gets reversed. Another good news I want to share, even you are genetically disposed to have diabetes, hypertension, infarction, coronary artery disease, whatever thing, if you are going to follow the lifestyle for 9 years from today, the genes are all epigenes of phenotype, they loses that effect, and without of the diseases, the genetic mutation to positivity, and thereby they become disease-free. So please remember, job is not a tension or pressure. Reason why the money is very important, they lose happiness in earning and they become victim. That's what I used to say, everyone. Please add any number of zeros after 1. The zeros will have value only when what you are existing, and work is worship. Work and life is very important. I want to ask all the audience, which nuts contains maximum cholesterol? Elango. Sendil, or it may be just 2
Sir,
minutes. I finish.
no nuts is having cholesterol, sir.
Oh, very good.
Passionate, sir. Dry fruit. All dry
All
fruit.
nuts are zero cholesterol. Very glad, Sendil, because any food from vegetable origin, zero cholesterol. Please remember that. So when the TV they invented was so obese, the person who was watching was very lean. Now the TV has become very lean. See, the person who is watching, they become very obese and victim for all of us. They come to us. So both active and passive. Please remember the most important concept. Please tell our younger students and generations, sitting is a new smoking. That is, if you're going to sit 10 hours continuously in one place, is equivalent to smoking 20 to 30 cigarettes. So every an hour they must stretch out, and then 10 to 15 seconds is enough to go back. So this dreadful combinations, alcohol, smoking, phosphorus, and sleep is very important for all diseases. You must go into the alpha mind. Always sleep like this better. You must sleep within 7 minutes, and you must all sleep minimum for 7 hours. Sleep and happiness just like a butterfly. You want to catch, it will go off from you. But the moment you are happy and serenity, it must come and sit on your palm. So food is, please remember, never take full stomach. Off stomach food, quarter water, quarter empty. And please finish your dinner 3 hours before going to sleep. Never exercise, breakfast nicely, lunch less, and dinner very much less. In the diet sheet, one quarter தண்ணி போடலாம்னு எழுதிட்டேன் தமிழ்ல, quarter தண்ணியை பார்த்து தப்பா எடுத்துக்கிட்டான், அதனால சொல்றது இல்லை அது வார்த்தை. So மனிதன் அமைதியாக இருப்பது கருவறையிலும் கல்லறையிலும். So the line is between the two is the line of our life is only நம்பிக்கை, தன்னம்பிக்கை, மூட நம்பிக்கையற்று அமைதியுடன் வாழ்ந்தால் the line can be extended. If you lose that அமைதி, it will get shortened. Both are in your lines only. So he wants more, still more, till is no more. Never give the room. Please see this. Everything is fast. Heart beats faster. Life ends faster. So please avoid hurry, worry, curry to get buried. So to live for more than 100 years, please do exercise, aerobic 100 hours per year and meditate 100 hours per year. So all the things will less than 100 and will live for more than 100 years. So please, when you're looking at that time, look at always now, live life better. Literally, if you're given 3 kings, we must kill 2 kings. That is, you must kill smoking and drinking. 1 king we must keep it is walking. So please, the happiness only in your fingertip. Control yourself. Alternate if necessary. Delete the unwanted things. Please remember the last life is a calculator. நல்லதை கூட்டி, கெட்டதை கழித்து, அறிவை பெருக்கி, நேரத்தை சீராக வகுத்து, சமநிலையில் வாழ கற்றுக்கொண்டார். நாம் அனைவரும் 100 வருடம் கடந்து வாழ முடியும் என்று கூறி, நேற்று என்பது வணைந்த பானை, நாளை என்பது மயில் மீது இருக்கின்ற பூனை, இன்று என்பதுதான் கையில் இருக்கின்ற வீணை என்று ரசித்து வாழும் பொழுது டிசீஸே வராது என்று சொல்லி என் நம்பர்லாம் கொடுத்துருக்கேன். இந்த அருமையான பிளாட்ஃபார்முக்கு நன்றி கூறி, நான் என்னுடைய மாணவி, அருமையான மாணவி, என்னை விட பல மடங்கு அருமையா செய்துட்டு இருக்காங்க. நம்ம இந்த ஷேரை ஸ்டாப் பண்ணிடுறேன். And I am more anxious to listen my dear student. She was used to arrange all my classes when she was a DM student, and she is doing much better than Chokkalingam. I am very proud. I am anxious to hear my students talk. Thank you all very much for patient audience. Thank you very much, Ilango, Sendil, everyone.
Super, sir.
Super.
Excellent.
So much, sir. It is
Yes.
a great honor,
Yes.
and I'm truly humbled for you being here to moderate this session, sir. Actually, I have no words to speak after you. My respects to you, sir. And my good evening to all respected senior professors and respected seniors and faculties of Indian Medical Association. I thank one and all for having given me this wonderful opportunity. I thank my friend and classmate, Dr. Sendil Kumar, for having invited me. But to speak after Professor V. Chokalingam sir, it's a very difficult task. But I will share a few insights for the sake of students. So the hypertension update. So the blood pressure categories we know now. What has been previously now is changed. 120 to 129 is now considered as elevated BP, and high blood pressure stage 1, 130 to 139 and 80 to 89, and high blood pressure stage 2 is 140 or higher and 90 and higher, and more than 160 and diastolic more than 120 comes under hypertensive crisis. So we know these are just numbers, but what is more important is that the previous guidelines have been slightly modified, because after the sprint trial, they've also found that the pre-hypertension group has been redefined now, and the age categories have been gone now. So this is the new category. As many seniors have already mentioned, guidelines are there only to guide us. But we have so many individuals, we treat patients, they are just not black nor white, they are shades of gray. So each individual is different, and we need to treat them individually. For example, when assessing a patient with hypertension, not only the ESC and ACC guidelines, we have to take a proper history, their background, their genetic workup, what is the age, the comorbidities, whether they have any renal issues, whether they come under any form of secondary hypertension, and what drug could be optimal for this patient, what is the electrolytes level, what is the thyroid status, what is the whether they belong to any Cushing or habitus, or are they on any drugs that increases the blood pressure. So everything should be kept in mind, and these patients should be assessed in toto and not just starting them on any one drug or two drugs. We have to individualize and treat them accordingly. So a simple way of measuring the blood pressure, many in clinics it is being measured by the staffs. So always avoid caffeinated or alcoholic beverages 30 minutes beforehand. Sit quietly for at least 5 minutes and allow your back to be supported and your legs uncrossed. Support your arm and your at the hospital. Wrap the cuff over the back.
Santosh, mute everybody. Santosh, mute everybody.
Don't talk during the measurement. Leave the deflated cuff in place. Wait a minute and then check the recordings again. If necessary, we can always have a home monitoring as well as the ambulatory blood pressure monitoring, which is very essential. And lifestyle modification has been dealt extensively by Professor V. Chickalingam. I did not mention that, but the European Society of Hypertension, the master plan for hypertension, measure the BP. Very important, because we have the dippers and non-dippers. Suppose what are dippers we already know. Normally the blood pressure at night comes down than during the daytime. But these non-dippers, it could give us a clue whether they are secondary hypertensives. So very important in 24-hour blood pressure monitoring, wherein we could pick up the non-dippers as well as the reverse dippers. Who are the reverse dippers? Morning, the blood pressure is lower, whereas in the night, it surges up. So this simple monitoring will give us a clue whether we are dealing with secondary hypertension, or these patients, the non-dippers and the reverse dippers, are prone for atherosclerotic heart diseases, and risk of stroke is higher in them. So we have to, so we need to assess the patient, measure the BP continuously, and also evaluate the response to treatment. So we have either we can do it at home blood pressure monitoring, or an office blood pressure monitoring, or blood pressure, ambulatory blood pressure monitoring. There are these three types of monitoring. So conditions, clinical conditions that support the use of home blood pressure monitoring or ambulatory blood pressure monitoring are those with white coat hypertension, which is very common, and grade 1 hypertension on office blood pressure monitoring, and marked office BP elevation without HMOD, that is without target organ damage, and conditions in which masked hypertension is more common, high normal office BP or normal office BP in individuals where there is hypertension mediated organ damage is there, and in treated individuals. So certain other specific indications for more home BP monitoring is patients not willing to perform the ambulatory blood pressure monitoring. Recently, we had a study where they were subjected to ambulatory blood pressure monitoring, but many patients, because of the continuous inflation, they were not willing for such monitoring. So those patients can have a home BP monitoring. So assess the patients, have a thorough clinical history, evaluate from head to foot, because the target organ damage, just the examination of the fundus, the retinal examination can give us a clue. Then the assessment of the heart, the kidneys, proteinuria, all those things, a spot UC ratio, everything is very important because these things can help us identify these patients. And the risk factors has been already. One important risk factor, what I would like to highlight nowadays is obstructive sleep apnea. We have to evaluate these patients with obstructive sleep apnea because many a times sleep study is not being done for such patients. And obstructive sleep apnea is now one of the increasing causes of hypertension, and we need to treat them perfectly. Once we control this obstructive sleep apnea, but diet, lifestyle modification, or an ENT procedure or something, or if they require a BiPAP or a CPAP during the night hours, definitely hypertension can come under control. So always look into the etiology of hypertension, the causative agents for hypertension, and once again, we need to control them depending upon the stages of hypertension. We need to put them on drugs. So straight away, for example, now, though AC inhibitors and ARBs are now considered as the first line along with calcium channel blocker. But remember, for AC inhibitors or ARB, we should always assess. We have to rule out renal artery stenosis. We have to rule out acute kidney injury, especially the rising creatinine more than 2.5, as well as a serum potassium level going above 5 or 5.5. Definitely, we need to be careful. So in such patients, we cannot give. But for myocardial infarction, for cardiac failure, definitely they come in the first line along with the hypertension. AC inhibitors and ARB definitely has got the first line. So along with that, calcium channel blockers, once again, whom to introduce a calcium. For example, in an acute MI with hypertension, we cannot immediately start them with calcium channel blockers. Once they get stabilized, for elderly patients, as well as hypertension with renal problem, it's not getting controlled. Definitely calcium channel blockers has a main role. So this slide summarizes the history, physical examination, EGFR, the potassium, sodium values, the cholesterol levels, simple ECG monitoring, echocardiography, very, very essential, and MRI and coronary calcium are only if essential, and simple ultrasound and Doppler ultrasound to rule out a renal artery stenosis, carotid ultrasound to assess the intimal thickness. What else should we add on to these patients? And what is their ankle brachial index? For peripheral arterial disease, we cannot give a non-selective beta blocker. It could be hazardous for the patient. A CT and an MRI assessing the cognitive function. What is their, a fundoscopy, a retinal evaluation to assess the microvasculature. So this has to be done, and we have to segregate these patients. And whether we are dealing with a hypertensive emergency or a hypertensive urgency, that also should be taken. And then only we should start treating these patients. So when to refer a patient with suspected secondary hypertension for further workup, a mild aortic syndrome, a coarctation of aorta, always, my professor used to always tell me, we should bow down to the patient and respect the patient and touch his feet, then only we will never miss coarctation. Even in young children, sometimes coarctation is a cause of secondary hypertension. And only if we palpate the low limb pulses, we will be able to pick up that absent or feeble pulses, so that this is a treatable condition and we can always treat them. And remember also the renal parenchymal diseases, renovascular hypertension, renal vascular hypertension and atherosclerosis, then the Cushing syndrome. So all the endocrine disorders, hyperparathyroidism, hypothyroidism, all these things can be a cause of a pheochromocytoma with labile hypertension, wherein in pheochromocytoma, we need to give an alpha blocker followed by a beta blocker. So it's not just following the guidelines. We need to know, get updated with the guidelines. What is the latest? Now, in the latest 2025, they are actually bringing in SGLT2 inhibitors because it reduces the systolic BP by around 6 millimeters and diastolic BP by 3 millimeters. So it is very essential. The ESC, the consensus statement has included it, and they are going to bring it in 2025 guidelines. So though the guidelines are enormous, but still we should know what can be given and what not to be given. Always, even SGLT2 inhibitors, if the eGFR is less than 30, less than 15, we need to be very careful in that. And now the newer drugs, finerenone is coming. So we have so many newer drugs, but rightly said by the pulmonologist, senior pulmonologist, that always guidelines and everything, newer drugs come into vogue. But we should know what stands for a longer period of time. What I would like to treat for my own brother or sister or my parents, I would treat for every individual, assess them from head to foot, analyze each and everything, and then start the drugs. Because a simple antihypertensive can be given even by a pharmacist. It's not so. We have to individualize and treat. So this is the therapy. This is all the guidelines, but we know that grade 2 hypertension, when target organ damage, or in CKD more than 3, or with the cardiovascular disease, then at least we have to monitor them frequently, bring down the, so how low, now how low you should bring these patients. So 120/80 is the ideal. Bringing it below 120/80 doesn't have an added benefit according to the guidelines. But as Professor Chokkalingam sir said, as much as tolerated by the patient without postural hypertension, depending upon the age of the patient. An elderly patient, if you reduce much lower, there is a risk of orthostatic hypertension. So always record the BP on lying down, sitting, and standing, so that we do not miss this postural hypertension. And always remember, an ambulatory blood pressure recording has a lot for us to give. And so once again, the lifestyle interventions, restriction of sodium intake, weight reduction, and another important thing is augmentation of potassium intake is very essential. All the whatever tender coconut or avocado, which increases the potassium, is essential. But once again, remember, if the patient has got a renal problem, a CKD, we cannot have an augmented potassium intake. So this is for normal individuals. We have to remember that. And this is, so once again, the guidelines say ACE or ARB or plus a calcium channel blocker with or without a diuretic. But remember, start with a single dose. If the BP is very high, we can start with two drug combination. That is the recommended as much as possible. Then add a diuretic, and a beta blocker can always be used, especially in the setting of acute myocardial infarction. It is definitely, and in the presence of arrhythmias like atrial fibrillation, definitely beta blockers are very helpful, both supraventricular and ventricular arrhythmias. Beta blocker has got a very essential role. Now, talking about true resistant hypertension. So when we call it as resistant hypertension, when the patient is on 3 or more drugs, and along with the thiazide diuretic or any diuretic, and still the patient's BP is high and not getting controlled, then they are true resistant hypertension. Definitely a mineralocorticoid like a spironolactone can be added on them. But once again, remember, when we add a mineralocorticoid, we have to remember the serum potassium should not go beyond 5.5, but the guidelines say at least more than 4.5 we should not give. And an eGFR less than 45, do not give it. If it is not there, we can very well give them these drugs. And we can also combine a beta blocker with the alpha or a centrally acting agent. A direct vasodilator can be preserved. And I'll come on to the renal denervation in the end. In heart failure nowadays, SGLT2 inhibitors has got a primary role. And if the renal parameters are okay and the eGFR is more than 30 ml and there is not much of hyperkalemia, we can start them with ARNI. The Chinese guidelines have included ARNI for angiotensin receptor neprilysin inhibitor now for resistant hypertension, but the European and ACC haven't brought it into guidelines, but there are certain consensus statements evolving on this aspect. So when the eGFR is more than 30 ml and in resistant hypertension with heart failure, that is important. Hypertension per se can cause heart failure. So hypertensive heart disease. So these patients, ARNI it is being speculated, but not into the guidelines, only in certain consensus statements. And in CKD, once again, we can use SGLT2 inhibitors until the eGFR is up to 30. And always remember, for senior people, we need to consider, we have to apply each and thing. As I said, isolated systolic hypertension, especially in an elderly, more than age 60 or 70 years, we can start on with a low dose thiazide diuretics. But always remember, we need to monitor the cholesterol levels. Always, we also need to check in their electrolytes and monitor them carefully. So these are, we need to, they have to come for frequent checkups. It is very essential, or they can monitor the blood pressure at home and they need to be modified accordingly. And even they can report to us over the phone, and they have to come periodically. And remember, always we have to check for any target organ damage whenever they come to us, an early sign of target organ damage, so that our aim is to prevent target organ damage or treat it early so that it becomes irreversible. Now, one line on hypertensive disorders of pregnancy, we can have chronic hypertension, which is superimposed or on pregnancy, or a gestational hypertension, which develops only after 20 weeks of pregnancy, or patient becoming a pre-eclampsia, developing eclampsia plus along with the HELP syndrome or with seizures, then developing a full-fledged eclampsia. So hypertensive disorders in pregnancy is of great caution now. And nowadays they say pregnancy-induced hypertension, this women on long-term follow-up, they develop aortic stenosis. So remember, pregnancy-induced hypertension not only affects the mother and the fetus and the mother on long-term follow-up, there is a risk of aortic stenosis and development of hypertension and hypertensive heart disease in the mother. So it is very essential that we need to treat them, catch them early, treat them, monitor for signs of proteinuria or any end organ damage, because we are dealing with two lives, the mother and the fetus. So the maternal complications, we know mortality, patient may develop myocardial infarction, a stroke. It is a risk of peripartum cardiomyopathy, spontaneous coronary artery dissection, and a postpartum hemorrhage and placental abruption, and long-term hypertension and diabetes, hyperlipidemia, stroke and vascular dementia, atrial fibrillation, and venous thromboembolism, CKD, and cardiovascular diseases. And now in 2025, ladies and gentlemen, they say that aortic stenosis could be could be because of a previous history of pregnancy-induced hypertension. And fetal complications and innumerable small for gestational age, stillbirth, preterm delivery, cardiovascular diseases on long-term for the fetus, which is not being evaluated. We treat PH, we leave them. We need to follow up both the fetus and the mother, and the risk of the fetus developing hypertension, stroke, and cardiovascular disease in the long term is of real concern, and we need to treat them early. These symptoms, I think every one of us know, so I need not go into the detail. But management of hypertension in pregnancy nowadays is mainly by labetalol. We give the maximum dose of labetalol along with, if necessary, amlodipine if it's not getting controlled. Alpha-methyl-dopa is now, these three are the main drugs which we can give, because ACE inhibitors and ARBs we cannot give during pregnancy because of the risk of renal dysgenesis and pulmonary hypoplasia. And beta blockers, atenolol especially, we don't give. But in peripartum cardiomyopathy, along with the hypertension, PAH, we can give them a low dose of metoprolol or bisoprolol, which can be given monitoring the fetal heart rate if essential. But atenolol is not given. Spironolactone, because of the fetal anti-adrenergic effect, it is not given. And remember, IV labetalol or hydrolysine can be given if necessary. And to Maxelf for seizure prophylaxis. And this is a case of, once again, done in by us in our institution, a coarctation of aorta, pinhole coarctation, which could not be crossed retrogradely. And using the 5 French multipurpose catheter, we just negotiated and crossed it and externalized. And this is, we are able to see a complete, the coarctation nil gradient post-procedure. So remember, coarctation of aorta is a treatable cause, and always we need to examine the patients, especially the students who are listening, examine the peripheral pulses completely, and it is a treatable cause. And we can always treat them. Though blood hypertension may not reverse completely, at least most of them it will get reversed. Few may continue to be hypertension, but it's a very rewarding and procedure for such young patients. It is very rewarding. Now coming to the almost to the final stages of my talk, what is new? Renal denervation. For whom do we give this renal denervation? Because the renal sympathetic afferent nerves, the kidney as origin of the central sympathetic nerve, the renal afferent nerve, they cause hypertrophy, arrhythmia, oxygen consumption, sleep disturbances, vasoconstriction, and insulin resistance. So if the patients are not being managed, even with more than 3 drugs, all the drugs has been exhausted, and still the patients continue to be hypertensive, then now they have indicated, apart from all the 5, apart from the routine 3 drugs, including a diuretic itself, they have given, but still we also exhaust the centrally acting drugs and even an aldosterone inhibitor. Still, we are not able to control the hypertension. The patient continues to be having high blood pressure. Then this renal artery denervation is a technique where we use the spiral catheter to engage the renal arteries and do this renal denervation. It's a simplicity RF, a radio frequency system. The inclusion criteria of systolic BP more than 140/90 and an ambulatory BP. This is according to the guidelines, but we do not do it for such patients. More than 180/100, despite all the drugs, patient continues to be symptomatic. Then we can consider with the informed age more than 80 years. The exclusion criteria, we need to exclude secondary hypertension, renal failure, then creatinine levels are high, or an eGFR less than 45 ml per minute, an acute EMI or acute stroke during these, and a valvular stenosis, and an unfavorable renal arteries, and serious coagulation disturbances. Definitely, we need to. So this is the renal denervation system, and the Lancet has concluded that though the guidelines they say 2B, but in resistant hypertension, despite 3 drugs, including a diuretic, and patient not responding, if there are no contraindications, definitely this technique can be applied without major complications, and it can be beneficial for. So one final slide is, what is the legacy effect of antihypertensive control? This is the new topic which is coming and published in the European Heart Journal. What is legacy? Legacy is getting inherited. Likewise, when we treat hypertensive patients, when we start them early, the effect of the drugs, the beneficial effect of the drugs as that legacy effect, it is being there for some time for these patients so that they maintain the benefits of this, and the target organ damage, cardiovascular damage, atherosclerotic damage, stroke risk, everything is being reduced. That is called as legacy effect of blood pressure measurement. That is very essential. This new terminology has now been published in the European Heart Journal. So we need to treat patients, get them young, treat them early so that we can prevent the side effects. So finally, I thank one and all for patient listening. And ladies and gentlemen, my final words are, we have to examine the patient as a whole from head to foot. Dear students, it is very essential. Examine the patient thoroughly, ask for the personal history, spend time with the patient, and advise what Professor Chokkalingam sir said, diet, lifestyle modification, avoid stress, be happy, and then if necessary, start on the drugs. Which drug for which patient has to be optimized. Thank you so much.
Cecilia, we all must give a very big hand for my student Cecilia.
Thank you. Thank you.
It's a very great masterly presentation. That is what I have been telling everywhere. My students are doing much better than Chokkalingam. You are one of my students like that. I'm very proud. Now this topic is open for discussion. We can ask question and answers. We can have, and we have spent some time with interacting with Cecily. Thank you. It's open for discussions, and we can stop. Sendil, stop sharing.
Yes, sir. There are some questions in the chat box, sir. How
As
common
we can,
the diagnosis
Sendil, you can stop
yes,
the
sir?
sharing. Slides we can continue.
Are you hearing, sir?
I am hearing, and
Yes, sir.
stop. Very good. Very good.
Yes, sir. How common the diagnosis in the general practice? Labile hypertension or systolic hypertension?
Yes.
How common?
Silly.
Yes, sir. So
Angela?
both are actually common, but systolic hypertension is more common in the elderly. Younger patients, labile hypertension is more common. Elderly patients, isolated systolic hypertension is more common. Younger patients, labile hypertension is more common.
Okay. And the next question, is the salt restriction a must for all hypertensive in tropical countries like India?
Salt restriction is we need not cut down the salt completely, less than 4 grams of salt, because many patients, they take some diuretics or increased sweating during summer. So if we restrict salt completely, they become very weak and fatigued. So the sodium levels has to be monitored, and it is not complete. We should avoid extra salt like pickle, puppets, things bought from the grocery like bread or cheese. All those things, extra salt has to be avoided. And once again, that also depends upon their renal parameters. What is their renal functions test? What are the drugs they are taking? All those things, whether they have heart failure, or it has to be individualized. But generally, less than 4 grams of salt is for normal patients.
I really am very happy, Cecily, about the salt and hypertension. But generally, we people take about 10 to 15 grams, even 20 grams. So what I'm requesting is, never add any table salt in the dining table. And please educate the people there is invisible salt in every diet, even rice, wheat, vegetables, they contain invisible salt. Generally, we're tempted for the taste of the tongue, but we add salt, it is not good for us. So what I'm requesting is, cut down the salt intake. Why you are clean about salt intake is, once you take extra salt, it will retain the more water for the sodium because osmotic one, and thereby volume increases, thereby blood pressure goes up. So salt restriction is really important. As Cecily cautioned, many people what they will do is zero salt, and then they take diuretics, they lose the salt, and they go for hyponatremia. The hyponatremia became a dreadful complication, especially when it goes less than 115, more so less than 100. They feel very lethargic, fatigue, and everything. They may think because hypertension, one must monitor all the time blood sodium, serum sodium, and concomitant potassium also when they're using sodium losing diuretics. Very important. So hyponatremia is very dangerous only if we don't diagnose. So these are the points in relation to the salt.
Yes, sir.
And if you want to cut
Next
down
question.
the salt, ask them not to take pickles. The pickles, if you cut down, that half of the salt is reduced. Thank you, Cecily. Yes?
Okay, sir. Next question, sir. How often to take BP at home?
Yeah. If the BP is very, at least every 3 hours, but if we need to, if the BP fluctuation is more than that, frequent BP fluctuation even once in 2 hours, or if there is not much BP fluctuation, even 3 early or 4 early, that depends. We can always take, or if it's a stable patient, once in a day, it's enough, either morning or evening.
But here only one caution, Cecily.
Yes, sir.
The BP, some patients may be about, say, 5 millimeters is more. So for example, 140 instead of that 144.
Yes.
What happens? They become psychologically what happens? Every 5 minutes, every 1 hour, they get stressed up. As you know, some patients, LDL cholesterol instead of 100, 110, they get tensed up. So the tension will increase the sugar, cholesterol, blood pressure, and tell them not to monitor. They become psychologically dependent on that, no need at all. But initially, as she was telling that, there is a continuous, as your Holter ECG, there is an ambulatory BP recording is there. We can monitor it for a day or even for extended ambulatory BP monitoring, initially for treatment to assess what they are, especially elderly. They are going to have the history of syncope, fall like that, whether it's related to blood pressure or related to arrhythmia. These things may be very useful. One must be extremely careful. Those who are above the age of 70 and 80, when they are taking medicine for the high blood pressure or diabetic, please underline that never overcorrect. Under correction of is always better. That too after 80, allow the BP go little more, blood sugar more, because hypotension, hypoglycemia is dreadful, and we are going to do overcorrection. So only one caution for your patients, more older the age, when they are on drugs, suppose when they are getting up in the night during sleep itself, BP will go down. When they get up and they hurry up to the urine, and then you are going to strain for that one that produces hypertension. Many fall may occur during midnight when they're going to get up for urination. One must caution them all the things, precautions you must take. I really appreciate Cecily. Yes?
Yes, sir. How to overcome amlodipine-induced fetal edema?
Yes, we need to
Clinidipine will cause edema.
amlodipine-induced fetal edema. We need to stop amlodipine.
Your voice is not clear, Cecily. Come closer to the audio.
Yes.
Yes.
Now am I audible, sir?
Yes, now clear.
Okay.
Yes, sir. We need to stop amlodipine and we have to switch over to a thiazide diuretic or an ACE or an ARB, which will cause mild diuresis. So if it treats to amlodipine-induced fetal edema can be reversed. But suppose we are not able to give, then clinidipine is a better choice, but still all calcium channel blockers can cause fetal edema. But the intensity is little less with clinidipine, but still they can cause. So normally when a patient comes with amlodipine-induced fetal edema, stop amlodipine, switch over to an ACE inhibitor or an ARB. If necessary, a low dose thiazide diuretic, it will settle down. In patients where it is contraindicated, especially in CKD, then we can go with clinidipine.
This amlodipine, as she added, generally I don't use nowadays amlodipine as a single drug or initiate amlodipine for blood pressure because majority of patients develop edema, then you'll be confused whether renal edema or cardiac edema. And more than ourselves getting worried, patients will be terribly upset. So generally, avoid amlodipine alone as a single drug for antihypertension because 20 to 30% they will get edema. That is better to avoid it. And one caution I want to tell my colleagues here is when a person is having hypertension and angina, for example, if you are going to give only amlodipine, please remember it will produce reflex tachycardia and it will produce aggravating angina. So whenever associated IH3, amlodipine always must be combined with a beta blocker, provided it's no contraindication. All the things you must titrate and carefully give it. Nice answer, Cecily.
Yes, sir. Yes, sir. Yes, sir. The next question. Why thiazides recommended to be ordered in very elderly patients? Is it recommended to add even when the patient is maintained normal on CCB and ARB's combination therapy?
It is not recommended for all. It is the third drug to be included. But if an elderly patient comes with isolated systolic hypertension alone, for example, the BP is 160, diastolic is 70 in an elderly, then we can add a thiazide diuretic alone. Not for youngsters or anybody. But along with two drugs, as Professor Choklingam said, we are putting an ARB or an AC inhibitor. That is a hyperpotassium increase. So we can always add a thiazide diuretic as a second line of drug or a calcium channel blocker or a beta blocker. That we have to individualize. Not that all patients should receive a thiazide diuretic. It is not the norm.
Next question. BP medicine stopped for 3 months, but the BP is maintaining normal for 2 months. After that, gain rise. Why?
That is what I mentioned, no? So we always have the legacy effect of antihypertensive drugs. Once it is well under control, it can get maintained, but not for 2 months and all. But the beneficial effects can be there for some time when you take antihypertensive medicines properly. But it's not that for 2 months it is maintaining and then flaring up. It cannot be like that. It could be some other different reason. For example, you would have modified your diet, lifestyle, your weight would have reduced. All these things, the BP can come under control, as rightly said. Your stress level has come down, your weight has come. Definitely, all these things will reduce the blood pressure up to some extent. Whereas an acute stress can trigger a high BP. But the legacy effect of antihypertensive drugs, the beneficial effects, if you take antihypertensive drugs early for quite some time, the benefits remain for some more time for the patients.
And here in this platform, I want to tell recent American Heart Association conference, we decided above the age of 20, male and female, they must have 5 checkups. 1 blood pressure, cholesterol, sugar, ECG and XHS. Then every 5 years, after 40 every year, because the blood pressure is a silent killer. Same thing is true with diabetes and cholesterol also, unless you monitor them. The same conference was about 18,000 cardiologists attended in San Francisco. I stood up and asked them, instead of doing it at 20, at the age of 25, you get infarct, you may miss it. So the age may come down to 15. So I personally feel after next year, it may be after 15 years of age, because obesity has become now, and type 2 diabetes become even at the age of 15 years, all the things because of lifestyle. So one must monitor them, one must closely watch them, and as Cecily put it, all the factors must be monitored and governed. Yes?
Yes,
Any more questions, Sendil?
Yes, sir. So many questions are there, sir. Yes, sir. Yes, sir. Finish, Cecily. Finish.
Yeah, I would also like to tell just one thing. We need to screen from the teenage itself, as sir rightly said. I also personally feel definitely it has to be screened in the young, because we are seeing 17 years old coming with acute myocardial infarction. There is familial hypercholesterolemia. So definitely these children has to be screened in the teenage itself. Mast cell checkups has to be started in the teenage itself, especially after COVID. Definitely it has to be important. And many drugs, just like cough suppressant, many of the cocaine, many drug abuse. So it has to be screened early.
And one small question to all the people here. When is that atherosclerosis starts? When does it cholesterol get deposited? And one good news I want to say, as long as you are happy with the happy hormones, especially endorphin, whatever thing, the cholesterol in the blood only will be in the blood. It will never get deposited. However, LDL, unless it is getting oxidized, it cannot deposit subendothelially. So LDL, oxidation and deposition. So the moment if I decide to be happy, doesn't matter the cholesterol level or sugar, I can live without any end organ damage. But I cannot tell everyone like this. The reason is, the most important thing is, please remember, the level of happiness, endorphin, all the things are very, very important. So then we made a research about 20 years back. I was apart from India. So why not to give endorphin, then make the people happy? Then we extracted 10 cc of endorphin, but it was costing 20 years before 2 lakhs rupees. Okay, rich enough, I can have it. But please remember, it can work only for 10 minutes. So how much money you have to spend to be happy? But God or nature has given it to be internally happy. It keeps secreting endorphin, all the happy hormones. There is no drug at all needed. That is what I stress. So whatever thing you are now, please implement ourselves as doctors. All my teachers are now no more. I feel sorry for them. You will be surprised, Cecily. We joined 100 people in my class. 59 people already dead. I am even accepting, feeling sorry. You'll be surprised. 25% of my students are now no more because they know everything, they don't implement themselves. Please remember that it's a platform I wanted not to caution, because one must be take care of our health intact before taking care of the health of others. That's what I personally feel. This is a very great platform, Sendil. Cecily,
yes, sir.
And Ilango have moderated, and everything really, every time I would like to take part in this one, but I won't be talking hereafter. I want to only listener and learn from my students. Really excellent platform, Sendil. I learned a lot today.
Next question, sir. Sir, we have 10 more questions, sir. We'll move fast.
Yes.
The next question is how to manage BP variability in complaint patient.
BP variability in compliant patients.
We need to put them on our 24-hour ambulatory blood pressure monitoring, either for 24 hours or 48 hours, and see how much it is varying. If the variation is not causing a big difference, then we need not worry. If there is a real variation, and then we have to we have to put them on long-acting drugs so that the variability is reduced. For example, from a BD dosage to a single long-acting dosage so that the BP variability is reduced.
What is the treatment for diastolic hypertension?
Yeah, diastolic hypertension is can have an isolated like systolic hypertension, diastolic hypertension also. But the routine drugs, we can't use thiazide diuretics for such. We can use an angiotensin receptor blocker or an ACE inhibitor, which can be always combined with a beta blocker. And nowadays they are telling this SGLT2 inhibitors are very beneficial for this diastolic hypertension, but it reduces in a very low range only, 4 millimeters of diastolic BP. That depends on how much is the diastolic BP response, so that we can use a combination of these drugs.
Okay. What is the ideal BP apparatus nowadays?
Yeah, ideal BP apparatus is always a manual BP recording. That is the best. With the mercury manometer, whatever we are using previously, that is the best, still holds good. But of course, we have the aneroid meter and all the other thing. But the thing is, whatever BP apparatus is used, we have to do it ideally. The position of the position of the cuff, the tubings, everything, all those things should be kept in mind. Avoid caffeinated drinks. Do not cross the legs. All those ideal things has to be done.
Standardization is a problem, madam, for all these apparatus. Standardization is a problem.
Yes, sir. Yes, sir. That is why now they are bringing in the ambulatory blood pressure monitoring, which can have a standardized set of results at 24 hours monitoring, so that we'll have the average and it will be easy for us to monitor.
How management of hypertension, infertility workup, and drugs of choice?
In what? In infertility?
Infertility workup.
Infertility
Management
workup,
of hypertension in infertility workup.
Yeah, infertility
Yes,
during
yes.
hypertension can be present. It can also be predisposed in patients taking hormonal pills, and in PCOS, especially hypertension is a component of that. So in these patients, definitely diet, lifestyle modification is very important, along with drugs for PCOS like metformin can be beneficial. But for hypertension, since these patients can become pregnant anytime, once again, labetalol will be the first drug of choice, along with, if necessary, if the BP is very high, along we can add on an ifidipine or an alpha-methyldopa. But first choice is labetalol, because labetalol is safe in pregnancy. So these patients can get conceived anytime. So first choice would be labetalol.
How to treat refractory hypertension?
Yeah, refractory hypertension, as I've said, we have given them 3 drugs, routinely ACE or ARB, plus a calcium channel blocker. Definitely a thiazide has to be included. Now, along with the plus or minus beta blocker, then we can add on the centrally acting drugs. Before that, an aldosterone receptor blocker, either an aldactone or spironolactone, or the newer drug, which is the eplerenone, is beneficial, because these drugs are definitely helpful. And even if they don't respond with that, then coming to the centrally acting drugs like prazosin can be added to them. And still they're not responding. That is clonidine, everything can be added. Still they're not responding. Now is the time when we have to treat them with the renal denervation therapy if essential. They're not getting control and they are becoming symptomatic. They're developing flash pulmonary edema. Definitely that is the indication for renal denervation therapy. And always remember, identify secondary causes of hypertension. And before putting them on renal denervation or referring them for that, just verify whether they are really adherent to drugs. Verify with the partner whether he's really taking the drugs. Many times, lack of adherence. The patients tell, I'm taking drugs, but they have not been taking drugs. So adherence to therapy is very essential. Look out for secondary causes of hypertension, wherein we need to treat the secondary causes. Then finally, we can always refer them. That is the last resort.
Okay. Is it mandatory to prescribe a low-dose aspirin and clopidogrel for all hypertensive, which is ordered by the physicians? We, the anesthetists, find it difficult to subject them to the regional anesthesia in emergency.
Yes, sir. Remember, it is not indicated for all patients who are hypertensive. We have to assess the risk scoring system for them, whether they have associated dyslipidemia, strong family history of CAD, atherosclerotic cardiovascular disease risk calculator. We have to subject them to that, and along with diabetes, then only we are giving them low dose of blood thinners. So always remember, aspirin 75 milligram is not a big contraindication for any major procedures, but other procedures definitely, unless it is warranted, need not give them routinely a blood thinner like that. Only if they have the associated risk factors, they have an impending risk, the treadmill is borderline positive, their CT calcium score is on the higher side, then we can put them on a blood thinner, not as a routine. But since they may develop and they may require a surgery some 2 years back, we can't, for a cardiac patient, we can't be without putting them on a blood thinner because that's going to be life-saving for the patient.
So we the surgeons also facing the same problem, madam. Dr. Chokalingam sir, please, do you want to add anything in this matter? In the emergency, can we take the patient for surgery if the patient is taking aspirin?
That is what 75 milligram aspirin is not a big contraindication. In emergency cases, they can take up, there is no harm at all. But if it's not in 75 milligram is not going to affect you. Only if it is 150 milligram, then it's better to stop it for 5 days. Even then, if it's an emergency, you can take up, but you have all the armamentarium of cautery, everything to seal the hemorrhage. Then if it's an emergency, we have no other choice, because we are patient waiting for CABG, developing an acute MI, there is no other choice. They are on dual blood thinners, but they still take them up for surgery.
Okay.
So if it's an emergency, that's a different. It's a non-emergency, you can wait. Emergency, you have to take.
Telmisartan and amlodipine combination therapy, if causing pedal edema, what is the alternative drug?
Yeah, usually telmisartan, when combined with amlodipine, they don't cause pedal edema because there is the diuretic effect of the ARB, angiotensin receptor blockers. But still, if you develop pedal edema, you can add a low-dose thiazide diuretic. If the patient tolerates, definitely that will be better. Or you stop amlodipine, switch over to clinidipine.
Any role of centrally acting drugs like clonidine?
Yeah, clonidine only in resistant. Yes, sir. Clonidine
in 2 years of age.
Huh?
In 2 years of age.
2 years of age, very rarely we use centrally acting drugs. Only if there is a pheochromocytoma, then put them on alpha blocker followed by a beta blocker. Clonidine has not got a major role because clonidine is we nowadays use at the later stage of the clonidine. If you exhausted all the drugs, then we add on clonidine.
Okay. This olive oil and the red wine is good for cardiac.
Yeah, definitely, but everything has to be used in moderation.
What's the recommended combination hypertension therapy in very elderly of 80 years old? Is metoprolol a good choice than amlodipine?
In 80 years of age, once again, that depends. If the heart rate is more than 100, a low dose metoprolol can be used. But if the heart rate for the elderly, when we use a beta blocker, we need to be very careful because already the sinus node is at dysfunction in the elderly age group. So when we are using a beta blocker, it should be a very low dose, only if the heart rate is more than 100, because they suddenly go in for bradycardia and AV block in elderly. So remember, for elderly, the first choice would be a thiazide diuretic along with a calcium channel blocker if necessary. Third only is a beta blocker, that also very low dose beta blocker. Never go aggressively with beta blockers in the elderly. We are seeing many patients coming with symptomatic bradycardia, giddiness, heart blocks. So their sinus node is already at danger. So better drugs are thiazide diuretics, calcium channel blockers, ARB and AC inhibitors, low dose can be given for them if their renal parameters are okay. Beta blockers only there.
There any questions from the forum? Any participants?
We can wind up the session, sir.
Yes, sir. Yes, sir. Yes, sir. Jayaraman, sir.
Yeah, good evening. Namaste.
Sir,
we had a
thanks,
wonderful, I'm Dr. S. Jayaraman. I'm a secretary, IMA AMS, pulmonologist. So I am very happy to give vote of thanks. What a session. Today's. Yes, sir.
Before that, one small comment for everyone. Whenever people with hypertension, when they're elderly, if you are going to exhibit antiplatelet aspirin, one must be extremely careful for cerebral hemorrhage. So unless you are going to take precaution, we may end up with the CVA like that. That also is covered. One must be very careful.
Spontaneous bleeding, sir? Spontaneous.
Yes, because hypertension itself, they make them prone for bleeding. By chance they had any stent or IH like that, you are going to give them platelet clopidogrel aspirin, they make them more prone for cerebral hemorrhage. Very important thing. So one must be very monitoring carefully. All the drugs are very effective one, but just like that we cannot give. And tell them lifestyle modifications are must for them, everyone. And most important thing for younger generation is please remember the primordial prevention of lifestyle. It must start, and don't teach the children that they should be like that. Parents must, elders must follow the lifestyle, that children will follow the footsteps of parents. So all the things must put together and make the society healthy. Yes, Jairam.
Thank you very much, sir, for the wonderful take messages from both the speakers and the moderators. Wonderful. Today's enjoyable day. Lot of take-home points. Today is the World Asthma Day, and to commemorate the World Hypertension Day, a lot of star speakers, star moderators today. We're all enjoyed Professor Sokalingam sir's wordings, initial slides. So Magilchi, Amedi. அதோட நம்ம பயணிக்கணும். மகிழ்ச்சி நோக்கி பயணிக்கக்கூடாது. The lot of take home points. So exercise very very important. So negative conflicts, எதிர்மறையான எண்ணங்கள் இருக்கக்கூடாது. So diet plays a very very important role. Sleep plays a very very important role. So we have to have the balanced in all the things and all. So we had a wonderful talk today from the cardiology perspective of hypertension management. Professor Dr. Cecily Mary Majella ma'am did a wonderful, awesome, crisp and clarity presentation. So what are the causes of secondary hypertension, OSA, sleep apnea, the lot of renal hypertension. So we have to treat effectively. So nowadays we are all practicing in an era of precision medicine. Each and every patient is different. So we have to have the personalized, individualized treatment. So we have to pinpoint the cause and treat accordingly. So we had a wonderful crisp and clarity presentation from Cecily ma'am as well as Professor Sokalingam sir. Awesome. There is no word to say. And we have a World Asthma Day moderator, Professor Dr. R.P. Ilango sirs. Wonderful moderation, wonderful take-home points. So inhalers are the standard care for the medications. So again, we have to spend with the patients. We have to teach the technique how to use the inhaler. So we have to have a meticulous history, examination, and pinpoint and individualize each and every patient. So today's speaker for World Asthma Day, Govindasamy, did a wonderful, nice, crisp and clarity presentation on GINA Guidelines 2025, the latest guidelines of Global Initiative for Asthma. So today is a wonderful day, lot of take-home points. I thank my Joint Secretary, Dr. Adar Sendil Kumar, for the wonderful, lovely speakers, lovely moderators. Really, really awesome. There is no word to say.
Thank you,
I
sir.
thank our IMA chairman, AMS chairman, Dr. Rajesh Babu sir, and all the IMA leaders and the delegates. So still they are awaiting to, so a lot of learn from all the stalwarts. So thank you all. Thank you, technical team. So wonderful day. Thank you very much. We'll meet again next month with a very good topic, very good speakers, very good moderators from the IMA Academy of Medical Specialties. Thank you all. God bless. Long live IMA. Thank you, sir.
Thanks a lot for everyone. I really honored Jairam.
Sir, Sokalingam sir, God will give you the 100th birthday also, sir. So
100%. Yeah. 100%.
I don't know.
100th birthday we are going to celebrate definitely.
As long as I'm alive, I want to be useful to the society.
Thank you very much, sir. Wonderful.
Students. So in the end, please avoid hurry, worry, curry to get buried.
Thank you, sir. Thank you.